Good afternoon, everyone, and good morning to those further west. I'd like to open this meeting, which is for the Advisory Committee on Infant and Maternal Mortality, formerly called the Advisory Committee on Infant Mortality. I'm Vanessa Lee. I serve as the designated federal official, or DFO, for the committee out of HRSA's Maternal and Child Health Bureau. I'd like to welcome our committee members, our ex officio members, and all of our invited speakers, panelists. And last but not least, welcome those of you that are joining us as members of the public. Thank you all so much for being here. We know this is a really busy time, but are looking forward to the next 2 days together. So I'm officially calling the meeting to order and would now like to turn it over to our acting chair to introduce himself. Ed?
Thank you, Vanessa, and good morning and afternoon to everyone. I always look forward to this meeting for a whole variety of reasons. It's been, like I said, this is our 4th December meeting, and it's been 2 years since our last in-person meeting when we met in person in December of 2019. Although I wasn't there, I was having a little medical problem in the DC area, and Paul Jarrett stepped in and covered for me. But that was our last in-person meeting, and I miss being together with you folks. But like I said, I really always appreciate this meeting because we come together from varied backgrounds and experiences and perspectives, all very interesting. And we come together from many places throughout the country, and sometimes even France when Jeannie's over there. But I come to you today from Minnesota, the land once inhabited by the Dakota and the Ojibwe peoples, a place whose health, for better or for worse, is influenced by the history of the people who've lived in this place and have made it their home for many, many centuries. So we also come together as part of a continuing history of ACIMM, and I'll even though it's ACIMM officially, I'll continue to call it ACIMM. That just seems to fit better for me. ACIMM, which was established in 1991, 30 years ago. This year is also the 30th anniversary of the Healthy Start program, which was established to reduce infant mortality rates by 50% over a 4-year period. Didn't quite make that, but that was the goal. A month ago, I was asked, along with Vanessa Lee and Belinda Pettiford, to talk about ACIMM at the Healthy Start 30th anniversary celebration. In preparing for that presentation, I recall the initial discussions in 1985 around a bill, Senate File 1209, to establish a national commission to prevent infant mortality. A hearing on that bill was chaired by Senator Dave Durenberger from Minnesota and Senator Lawton Childs from Florida, and it was held in Washington, D.C. And for some of you who've been around for a while, there are some familiar names who testified at that hearing. James Mason, Vince Hutchins, who was MCHB director or chief at that time, Joel Kleinman, Jim Marks, Sarah Rosenbaum, Stanley Graven, Charlie Mahan, and Sarah Brown. Also on that list were Paul Wise and me. Both of us were testifying before Congress for the first time. It was in Paul's testimony that I heard for the first time the term social determinants of infant health. And reviewing his testimony 36 years later was somewhat distressing in that what he said then is still relevant today. Let me give you just 5 excerpts from his testimony. He said, "The problems of low birth weight infants and infant mortality are not the product of geography. They are not the problem of being a heterogeneous society. They are a product of our policies." He went on, "A major concern is the persistence of social and racial disparities. The technological capacity of modern medicine cannot erase the legacy of larger social inequities. Equity in infant outcomes can only be achieved when inequity in infant outcomes is addressed and addressed directly. And the reduction in Black infant mortality related directly to a more fundamental commitment to a more responsible and just society." He was sort of reflecting many of the things that we talk about in our committee meetings over the last 4 years. My statement at that testimony was much less eloquent than Paul's, but reinforced many of the points that he made. I ended up my testimony by saying, quote, "The problem of infant mortality in this country is an issue of social justice. The survival and growth of infants and children depends on our acceptance of the responsibility to address their pressing medical and social needs. To ignore that responsibility would be an injustice not only to our children, but to our society. We need to make a commitment to the children of our country. We need to make them our highest priority and protect them from the political, social, and economic forces that pervade our society and too often are to the detriment of mothers and infants. And I still hold that belief today. So in light of that 36-year history, after which the issues affecting infant mortality in 1985 still persist today, and in many areas have even gotten worse, we could get discouraged. But I think collectively, as members of SACIMM, in our own limited way, we have made a difference. We have helped change the trajectory of the field of maternal and infant health ever so slightly, so that 36 years from today, things will be different than they are today. We have heeded the 1985 advice of Paul Wise and expanded the focus and shifted the priorities from programs to policies, from just medical care to medical care and social determinants of health, from race to racism. And we have helped highlight the needs of pregnant individuals and infants during a once-in-a-lifetime pandemic and a humanitarian crisis on our southern border. And we are addressing the needs of Indigenous women and children, a group too often overlooked, all with equity as our North Star. I think we've done remarkable work, and we continue to do this. And we have, for many of us, only 3 meetings left as members of this committee. So I urge all of us to make the most of these last 3 meetings and create some momentum that we can hand off to the next cohort of SACIMM members. So let's recommit ourselves to finding a different and I hope better way to make the necessary changes in our society that protect mothers and infants. Now, I had anticipated that we would have many more members on our meeting that we could introduce, and we were going to take a longer time, but today we just have us, and Paul Wise is not here because he's actually dealing with the Omicron problem on the border, so he will be coming tomorrow. So I won't do an expanded introductory time, but we will do a much shorter one. So let's go around and introduce ourselves. So let's have the regular members introduce themselves, and we'll start on my list up here as I see on my screen. Tara, you want to introduce yourself?
Good morning. My name is Tara Sanderlee. I'm the Senior Fellow and Director of Life Sciences at the Charlotte Lozier Institute, which is located in Arlington, Virginia. Today I am in Milwaukee, Wisconsin, or just west of Milwaukee, Wisconsin. So I'm really happy to be here and excited for the next couple of days.
Good. Jeannie Connery.
Good day to everybody. This is Jean Connery from California, often from Paris. I am past president of the American College of Obstetricians and Gynecologists, and I'm president of the International Federation of Gynecology and Obstetrics. Thank you.
Good. Steve Calvin.
Hi, Steve Calvin, Minneapolis, Minnesota. I'm a maternal fetal medicine specialist, and I am currently working with midwives to promote midwife-led primary maternity care integrated with the larger health system.
Okay, great. Magda Peck.
Well, good morning, everyone. My name is Magda Peck, and I'm an independent consultant with MP3 Health and a maternal and child health specialist. My academic affiliation is as professor of pediatrics and public health at the University of Nebraska Medical Center in Omaha, Nebraska. I continue to serve as senior advisor of CityMatch, the national organization dedicated to urban women, children, families, and fathers health, where I founded it as well 33 years ago. So part of that initial cohort, along with Healthy Start and many other things from initiatives that started 30 plus years ago, for which we are still doing due diligence. And this morning I woke in Richmond, California, on the banks of the San Francisco Bay, the ancestral lands of the Ohlone and Muwekma and Lujan peoples, to whom I give homage and appreciation. Thank you, Ed. Glad to be here today.
Janelle Palacio.
Good morning, everyone. I'm Janelle Palacios. I'm a nurse midwife, and I'm also a researcher and an independent consultant. I am currently in Sonoma County, which is the home to the Coast, Miwok, and Pomo people who are still here today. And I am looking forward to December's meeting with a lot of gusto. Thank you.
Good. Belinda Pettiford.
Good morning, everyone. Well, it may be morning, depending on where you are. Hello, everyone. I am Belinda Pettiford. I am in North Carolina. where I'm here as head of women's health for our state Title V. It is so good to see everyone. I am also the president-elect of AMCHIP. And as Ed talks about Healthy Start, I am a board member of the National Healthy Start Association. So I do look forward to being with everyone today and always enjoy our meetings. Thanks.
Great. Paul Jarris.
Hi, Paul Jarris. I'm currently working in the area of the interface between nature and human health. I retired family physician, also public health official, commissioner of health in Vermont, led ASTO Association, whatever we are at, Association of State and Territorial Health Officials for 10 years, and most recently was with MITRE Corporation, leading as their chief medical advisor to their work with HHS. So happy to be here.
Yeah. So soon you forget, you can't even remember what ASTO stands for anymore. You've been out for too long.
I know.
Colleen Malloy.
Yes, hi, my name is Colleen Malloy. I am a neonatologist and pediatrician at Feinberg University, Northwestern University School of Medicine, and Lurie Children's Hospital in Chicago, and I look forward to this meeting.
Great. And as I said, Paul Wise won't be here today, but he'll be here tomorrow. Let's do the MCHB staff. Vanessa, do you want to quickly introduce yourself again?
Sure. Hello again, everyone. I'm Vanessa Lee. I work at HRSA's Maternal and Child Health Bureau in the Division of Healthy Start and Perinatal Services. And I have the privilege of serving as the designated federal official for this committee and a project officer in the Bureau.
And Dr. Warren.
Good morning or good afternoon. Michael Warren, I'm the Associate Administrator of the Maternal and Child Health Bureau here at HRSA and an ex officio member of ACIMM.
Yeah. And Lee Wilson.
Good morning, afternoon, folks. Lee Wilson, I'm the Director of the Division of Healthy Start and Perinatal Services, which has responsibility for the administration of the committee. And I'm very happy to be here with you and looking forward to the 2 days.
Yeah, good. And Michelle Lowe.
Good afternoon, good morning. I am Michelle Lowe. I'm the management analyst for the SACIMM.
All right, good. And I know we have a bunch of ex officio members on, and let me see if I can Danielle Ely.
Hi, I'm Danielle Ely. I'm work on the linked file with the National Center for Health Statistics. So the linked file is the birth and infant death file combined. Thanks.
Kristen Zickerman.
Hi, I'm Kristen Zickerman. I am the acting technical director of quality improvement at Centers for Medicare and Medicaid Services, and the lead on the Maternal Infant Health Initiative.
Great. Any other ex officio members that I can't see on my screen or on my scroll? All right, well, I hope we get some more as the meeting progresses. And we have some other speakers who will be introduced as they do some presentations a little bit later on. So welcome all. I'm glad you are here, and I hope you are ready for 4 hours with one break in between of good discussion and deliberation. Let's now move to reviewing the minutes of our meeting. One of our official businesses came in the briefing book. Anybody want to move approval of the minutes before we talk about them?
So moved.
All right, and is there a second to that?
Second.
Right, got a second. Any comments on the minutes?
This is Magda. I just want to reflect that we tend to take for granted the staffing that comes with this particular endeavor. And it has been very helpful to have this documentation, especially in trying to get perspective on our very first meeting, especially conversations with you, Dr. Warren. So I just want to say thank you to the staff that make this happen, and the level of detail gives us a thread to follow through and a chance to circle back. So gratitude.
Yeah, I second that, because I've been going through the minutes and they've been very helpful to be as comprehensive as they are. Any other comments? If not, all in favor say aye or raise your hand.
Aye.
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 Any opposed? All right, the minutes are approved. So the next on our agenda is federal updates. And normally we have MCHB kind of go first and do their updates, but we just heard from Dr. Warren in September, and we have a couple of other updates that we would like to get to. So we're going to not hear from Michael at Dr. Warren at this time for the MCH updates, although I do suspect that during the course of our meeting, we will probably get some input from him or Lee or Vanessa on what's going on in the MCHB. But one of the things that I've asked him, and they couldn't quite do this at this time, and I hope will, and what I hope will be our April meeting, kind of give us an update on the response of MCHB and other federal agencies on our recommendations that came out during the summer, so that we will get a more complete review of some of the action taken on the recommendations that we made. So in lieu of that, though, we do have two federal representatives, Kristen Zeikerman, ex officio member. She's acting technical director for quality improvement, maternal infant health initiative, Center for Medicare and CHIP services, Center for Medicare and Medicaid services. That's hard to get on a business card, Kristen, but I'm glad you're here. So I look forward to your update about what's going on in your shop.
Oh, thank you so much. We can move on to the next slide. Try to keep it moving here since I know we want time for all the presentations and questions. So just an overview of what I'm going to talk about today. Next slide. Next slide. Okay. So the Maternal Infant Health Initiative was launched initially in 2014 based on recommendations by an expert panel of within the field of maternal and infant health. 5 years into the MIHI, we were ready to take stock on where we were, what progress had been made, where there was still room for improvement. So we reconvened an expert work group to provide updated recommendations on where Medicaid and CHIP have a significant opportunity to influence change. So today, the MIHI is focused on 3 areas based on recommendations by the work group, including an increase in use and quality increase of the use and quality of postpartum care visits, an increase in the use and quality of infant well-child visits, and a decrease in the rate of low-risk cesarean deliveries. Next slide, please. So this figure shows the interconnectedness of these 3 areas and the emphasis that the work group wanted to put on the importance of both the mother-infant dyad care as well as care throughout the life course of both the birthing person and the infant. Next slide, please. So obviously equity is a big focus in maternal health outcomes. Currently, we are looking at 3 to up to 5 times the death rate in Black and American Indian, Alaska Native birthing persons based on other demographic factors, but it is up to 5 times the rate of maternal mortality. So it is something that we are focusing on across all 3 of our MIHI focus areas. Next slide, please. And this slide shows the importance of that postpartum period, and that over half of deaths happen in the postpartum period, with a third happening after a week postpartum, so usually after that initial discharge, and almost 12% occurring in what's considered the late postpartum period, or after 42 days postpartum. Next slide, please. Next slide. So there are special considerations for our Medicaid and CHIP population, especially in regards to equity and postpartum care, as these are statistics that were based on studies particularly done with women, which is why it refers to women, but likely translates to all birthing individuals. And so women enrolled in Medicaid are more likely to be overweight or obese and have comorbidities compared with both uninsured and privately insured women. Studies have shown that women who are Black and Hispanic and individuals that have a low level of education and those with coexisting morbidities, such as mental health conditions, have lower rates of this postpartum follow-up care. And despite lower or higher rates of postpartum depression, people of color tend to have a lower screening rate for postpartum depression. Next slide, please. So this is the most recent core set reporting data from our Medicaid and CHIP adult core set. And it shows that around 72% of women delivering a live birth had a postpartum care visit. This year, the technical specifications for this measure had changed to expand it from 7 days to 84 days after delivery. So that's why it's gone up. The median has gone up a little from previous reporting years, so not totally trendable. However, there's still a lot of room for improvement there. Next slide. And you can see on this slide that the yellow states are our lowest performing quartile states, while the gray states do not report on this measure. So we're continuing to also work with states that aren't reporting this measure to encourage reporting. Next slide, please. Along with the increase in attention to maternal care and postpartum care, there's also this evolving concept of postpartum care, where ACOG recommendations recommends that all birthing people have contact with their healthcare provider within 3 weeks, and also a comprehensive postpartum visit. And that plays into the quality of the postpartum visit, is the expansion of the scope, that it's not just about recovery from childbirth anymore, but includes also health education and infant care and feeding and contraceptive care, as well as chronic disease screening and management. So to look for these conditions that contribute to maternal morbidity and mortality post-birth, and to connect them with the proper care. We also understand that the systemic inequities are contributing in this period to the care that birthing people receive. And so also addressing that. Next slide, please. So part of the MIHI, our first learning collaborative, as part of this new phase of MIHI that launched in December 2020, was the postpartum care learning collaborative. So here we had a 3-part webinar series, which can all be found. The recordings of the webinars can be found on Medicaid.gov. And currently we have an ongoing postpartum care affinity group where we're working with 9 states on providing targeted technical assistance, one-on-one, as well as group learning work group sessions to improve the rates and quality of postpartum care in their state. Next slide, please. Our next learning collaborative is the Infant Well Child Visit Learning Collaborative, which, as you all know, the benefits of high quality well child visits do all of these things. So I won't read the slide, but next slide, please. Our recent core set reporting on this measure showed a median of 66% of children receiving 6 or more well child visits in the first 15 months of life, where the American Academy of Pediatrics and Bright Futures recommends at least 9 well child visits by the time the child turns 15 months of age. So this isn't even meeting the best standard of care recommendations, and only 66% of children are receiving those. So we know that there is a large room for improvement in this metric as well. Next slide. With the yellow states being the lowest performing quartiles in this measure. Next slide, please. And we know that Medicaid and CHIP beneficiaries are receiving these services at a much lower rate than other payers. So that's what this, with the lowest black line being Medicaid and CHIP, and the highest being PPO, private insurance, and HMO. Next slide. And then in addition, we know that the COVID-19 public health emergency led to foregone care with children missing a lot of these recommended visits during that time period, and continue, although it is catching up some at this point. Next slide, please. So the Infant Well Child Visit Learning Collaborative, we had a similar webinar series with recordings available at medicaid.gov, and we are currently in the middle of our affinity group providing TA to 8 states to improve their well child visit rates and quality. Next slide, please. And then our final MIHI Learning Collaborative of our final area of focus hopes to be launching in the beginning of 2022 is lowering the rate of low-risk cesarean delivery or NTSV cesarean delivery to improve health outcomes, since it is a factor associated with the rising maternal morbidity as well as infant complications as well. Next slide. So CMS has not been able to publicly report a low-risk cesarean birth metric. While it is one that is on the core set, it has never met the threshold of 25 states to be able to be reported publicly. So for the 2021 measurement year, we have replaced PCO2, which was the previous cesarean birth measure, with LRCD, which is a low-risk cesarean delivery measure based on CDC natality data. So CMS will actually calculate this measure on behalf of all of the states. So we will have data from all states, and we will access that through CDC Wonder. So that will be reported with the next cycle of core set reporting. So we will finally be able to publicly report on a low-risk cesarean delivery measure. Next slide. And this is a little bit more about the collaborative, and more information on that will be forthcoming as we schedule the webinars and have more information on the affinity group. Next slide. Next slide. We also have a coming in early 2022, a tobacco cessation for pregnant and postpartum women on-demand series of short videos featuring subject matter experts and state stories on successful programs to help Medicaid and CHIP beneficiaries quit smoking and remain smoke-free during pregnancy and after delivery. And there will be an opportunity for continued one-on-one coaching on an as-needed basis for that one. Next slide, please. And at CMS, we have a lot of other maternal and infant health activities. It's a major priority of this administration and our administrator. So you may have seen that the postpartum coverage extension guidance, a show letter came out this past Tuesday, the 8th, on guidance for states on the implementation of the new SPA option to be able to extend postpartum coverage in Medicaid and CHIP for 12 months post-delivery. In addition to that, we also have approved demonstration, Section 1115 demonstration waivers for a number of states extending postpartum care coverage as well. I included a little more information on the maternity core set. This says that we have 6 measures from CMS's child core set and 4 measures from the adult core set, which is the most current information as the SIB with the newest core set just was released yesterday, I believe, maybe Friday. And next slide, please. CMS also conducted an equity assessment focused on postpartum care, and that is where we also identified the need and the strong disparities with in care for Black and American Indian, Alaska Native postpartum individuals, and that led to a challenge.gov prize competition that we have partnered with the Office of Women's Health to put out. So just want to flag that we are trying to gather examples of innovative programs or ideas that have demonstrated improvement of care in these populations. And the deadline for that challenge submission is January 31st. Next slide, please. We also have a maternal health agency priority goal of improving maternal health and reducing disparities nationwide and globally by assuring the equitable provision of evidence-based high-quality care addressing social determinants of health, including racism, discrimination, and other biases across the life course. So I thought that was good to share with this group, as it is in line with actions here as well. And then I included the maternal health action plan from the Department of Health and Human Services with goals of reducing maternal mortality rate by 50% in 5 years, reducing the lower C-section rate by 25% in 5 years, which we hope our low-risk cesarean delivery learning collaborative will help contribute to, as well as achieving blood pressure control in 80% of women of reproductive age with hypertension in 5 years. Next slide, please. And I just included a list of resources. I know that we can't, that you can't click them directly for here, but when the slides are posted, you'll be able to easily get to those web pages. So thank you.
Thank you, Kristen. Let's open it up for a few minutes of questions. And Kristen, I hope you can stick around after the presentation of the Office of Women's Health, because I think there will be some discussions about the White House Maternal Health Day Day of Action, and I'd like to have both of you in on that conversation. But if there are members of the committee, if you could use the raise the hand feature, and I think, let me just say, we got Paul Jarris.
Thank you, Ed, and thank you for the presentation. I appreciate it. Particularly the potential to extend postpartum care for a year after delivery. I think it's incredibly important. Couple of concerns. One is that I saw from the initial tasking of your work, you did use, I think the term effective use of contraception was in there, and that was dropped over time. And in particular, I'm concerned about the either immediate postpartum or postpartum contraception to impact birth spacing, which is so important. And I know that when I used to oversee some of the insurance aspects of Medicaid, there were providers who actually, after doing a C-section on their private patients, would do a tubal ligation while they were doing the surgery. On their Medicaid patients, they wouldn't, and they'd schedule them back later so they could actually bill and collect better funding from Medicaid. So there were particular problems in Medicaid around immediate postpartum and postpartum contraception. So I'm wondering, you know, why that got dropped, and if it is going to be a focus, because it's kind of buried if it is in there still.
While it isn't, oh, I'm sorry, you can keep going.
Well, I'm going to make this a twofer, and you can decide what you want to do. The other thing I was concerned about is a lot of your explanations of maternal mortality were very clinical and medical, and I didn't see things like partner violence in there, drug overdose, and other things that fall outside the medical environment, but are actually much more impactful often with maternal morbidity and mortality than the classic health concerns. So take your pick.
Sure, I'll start with contraception. So that was a focus on in the original phase of MIHI, and what came out of that was contraceptive care measures. And so now we have 2 contraceptive care measures split into four measures on our adult and child core sets. 1 contraceptive care measure for all women and 1 contraceptive care measure for postpartum women. And those are further split into LARCs. And where contraceptive care postpartum got wrapped into was kind of our comprehensive quality postpartum care. So one thing that we have been working with states a lot on is the unbundling of postpartum LARCs, because that was a real barrier, was the Medicaid, separating out Medicaid payment for LARCs given in postpartum, that wasn't wrapped into the delivery and hospitalization fees. So, so it's something that we continue to work on, as well as exploring options for future measures related to patient-centered contraceptive counseling and such.
Thank you.
Then, I'm sorry, the second question was on...
Well, all the other factors affecting maternal morbidity and mortality outside of the classic clinical conditions, which often are more impactful.
Right. A lot of our data comes from the CDC definition of maternal, of severe maternal morbidity, which is those 21 codes that are largely clinical based. However, as we work with states on this, a lot of states are starting to calculate their own severe maternal morbidity rates and are including codes related to behavioral health, SUD, other things. Intimate partner violence gets into a little bit of like the pregnancy associated versus pregnancy related death, but it is something that is also we discuss as part of quality postpartum care, is the screening and referral for those types of situations as well. So it is something covered under postpartum care as well, and is something we are considering, especially like the behavioral health and SUD side of things, as conditions of maternal morbidity and leading potentially to mortality that are being addressed.
Thank you.
We'll have time for 3 more questions. We'll have Jeannie Conry, Steve Calvin, and Magda Peck in that order. Jeannie.
Thank you so much. And Kristen, great summary and a lot of information. I appreciate it very much. I did want to make one comment about the postpartum tubal ligations, that there are rightfully so some barriers or protections, depending on how you look at it, with the waiting period, that more often than not influence the ability to do a tubal ligation at the same time as a cesarean section. The mandatory wait for the Medicaid patients was put there to protect them, but in the end, it can also be a barrier depending on how you're looking at it. So just for us to all be cognizant of that. Second comment has to do with one of the things that we looked at, and I believe it was a meeting about 5 years ago, that looked at measuring the health of women as they began pregnancy, as an indirect reflection of preconception health, if you will, because too often our measurements are not gender-based and they're not reproductive health-based. So, for example, the measurements for hypertension control are not reflective of what ideal hypertension control can be. So I would say that we're strong advocates for making sure that we've got some gender-based and reproductive health background-based measurements, and we hold health plans accountable to those kind of things. Preconception care is a very difficult measurement, but the control of woman's blood sugar before she, at her first prenatal visit, is the blood pressure regulation at her first OB visit, is her weight, her use of tobacco, her use of a prenatal vitamin. All of those are reflections, indirect reflections of preconception health, and can be used as a measurement of adequate care. So thank you.
We totally agree with you. We believe that, healthy individuals become healthy pregnant individuals. So definitely that preconception period. And while we can't at CMS necessarily tackle that before time, if there's not for coverage yet, we're hoping, our hope is that that extension of postpartum care will put people in a better health status before going into subsequent pregnancies. So it's not ideal, but it's something.
And I will add, Women's Preventive Services Initiative just updated our contraceptive guidelines. So those will be posted very shortly. So very happy to say WPSI is addressing contraception access for all.
Great. Okay.
Within the Affordable Care Act. Thank you.
All right, Steve.
Yeah, Kristen, thanks for the report. I have a quick question. So looking at Minnesota is not in the list of states that is actually participating in. Is that an issue of kind of the executive branch in the state or legislative? I mean, where just in general, what advice would you give those in states that are currently lagging behind both in participation and in outcomes?
I think it depends on state to state why they don't participate. We try to outreach, especially to our lower performing states, and see what we can do to try to work with them to help them be involved in some of these technical assistance opportunities. But sometimes it's a bandwidth issue, sometimes it's a priority issue. Just states are stretched for resources and people, and so sometimes they have to pick and choose what they participate in and how, but we definitely try to. And that's why we're trying to roll out, like, for example, the tobacco cessation on-demand short videos to be able to offer some of those technical assistance opportunities to states that can't commit to a full affinity group. Or we have our webinar series that can be watched at any time after the fact. And we have a Medicaid and CHIP quality improvement mailbox that states can reach out to anytime if they need some additional assistance.
Okay, well, our hour-long thing later today too with the folks from New Jersey and California, I think that's the state and community projects, maternal health, that I think people will be interested in what those folks have to say. Thank you.
Good. We'll have Magda.
Thank you so much for the presentation. I have the privilege of co-leading the Data and Research to Action work group, Kristen, and so I'm going to put on a data hat. And I am also going to harken back to the notion that we seem to have a theme here that we've been doing at least this iteration for at least a third of a century, if not a full century, if not longer. So I'm perplexed, and help me understand the gaps in the data within CMS that you're looking at. You have a threshold of 25 states in order for something to be reported. Is that correct? That's what I understood. And yet I look at your
to report publicly.
Report publicly. Thank you for that distinction. I'm just noticing the gap in geography between where we get data and which states are participating in terms of Medicaid expansion and otherwise. And so I wanted to know, what are the incentives for states to participate in reporting so that we can have a more robust picture nationally? Is it a lack of capacity? Is it a lack of political will? And so I'm trying to get a sense of why are we not hearing now in almost 22 about basic reporting, particularly when the carrot is that you are funding these states in some way. So I'm looking at the correlation about who reports, who doesn't. And it tends to be states where, in fact, the outcomes may not be as good. And I am aware that at least in a couple of states, the governor's office will say, we will not allow that to be reported publicly because it will make us look bad. And so how do you wrestle with these data gaps that are there now 30 years into a program? And what with Medicaid expansion are you building in if that initiative goes forward with the Build Back Better funding, if it is passed? And more broadly, how do you bring some sticks to the carrots so that we have data we can rely on, that we can disaggregate by race and ethnicity, that we can include birthing peoples? Help us figure out how to make the data stronger so that we can have more confidence in it and use it better.
Right. I totally hear you. We are limited somewhat by statute because it is the Medicaid and CHIP core sets are voluntary reporting program by states. So the states we cannot require the states to report on this information. However, there are, but in 2024, the entire child core set will become mandatory reporting. So any of the measures on the child core set will be required to be reported by states, and in 2024, any behavioral health measures on the adult core set will be required to be reported by states. So that will be part of the maternity core set will fall under that, any of the child measures. And then if any, currently we don't have any behavioral health measures on the maternity core set. However, there are some that are being put forward to be put onto the maternity core set. So if that indeed happens before 2024, then those will be required as well. We currently by statute can't require the entire adult core set, but we are hopeful that eventually we will be able to. But that's the reason currently that we can't. And we are also doing our best to look at other data sources, like with CDC Wonder, and as we're able to we're looking into drawing more out of our own CMS TMSIS data to be able to calculate measures on behalf of states so that we can reach that threshold in some of the lesser reported measures in order to report publicly.
That's a great response. Thank you for that. And I will just follow by saying we at the Secretary's Advisory Committee on Infant Maternal Mortality have the opportunity to make recommendations, and which may or may not have influence, but we cannot be silent. So if this is an egregious gap, recognizing that it has been a voluntary system, and this is essential information for maternal and infant indicators to be part of mandatory reporting, perhaps we could have a follow-up conversation of what you hope that might look like. Similarly,
sure, and we have a process for annual core set discussion, and anyone can submit recommendations for measures for that annual review work group. So I would encourage you to utilize that process as well. If this group has ideas for measures that should be included.
Thank you. That is the role we were invited to play relative to the PRAMS data set. And so we have expertise and experience in doing so. And if we could have more specifics, that would be an opportunity. And similarly, as you talk about linkages, we'll be talking tomorrow about our linkage between health and housing. And I would be curious, as a quick follow-up, what is the connection between CMS data sets and those in other branches of government, particularly around housing or, say, eviction? Do you link those data sets, or are they being linked so that we can have a greater picture of upstream factors?
Now, I'm not aware of data linkages specifically with housing. We are exploring data linkages with CDC data as well as HRSA data, but we are still working through privacy red tape as well. So that is definitely an area of interest and continued exploration, but housing is a good point as well.
Thank you, Kristen. And if you can hang in there, and we'll have open it up for discussion after our next presenter also. Margaret Snyder is going to be presenting next from the Office of Women's Health. Dorothy Fink lost her voice. She got something going on with her, so she couldn't make it. So Margaret is here. So Margaret, maybe you could introduce yourself a little bit more, because we don't have your full criteria on the agenda. So Margaret, turn it over to you.
Okay, great. Thanks. Can everyone hear me okay?
I can, yes.
Okay, great. Yeah, I thought I'd go with the festive background. I see Michael's got one as well, so I'm in good company. So my name is Margaret Snyder. I'm a lead public health advisor in the Office on Women's Health and the Office of the Assistant Secretary for Health at HHS. I'm excited to brief you on some OWH initiatives that were promoted during last week's Maternal Health Day of Action. Next slide, please. So I'll start with a couple of the challenges that we have going on right now. So this first one is a racial equity and postpartum care challenge. And it's aimed at improving postpartum care for Black or African American and American Indian or Alaska Native low-income beneficiaries enrolled in Medicaid or Children's Health Insurance Program. That's a partnership with CMS. And the emphasis here is on follow-up care for conditions associated with morbidity and mortality in the later postpartum period, including conditions like diabetes, postpartum depression, or postpartum anxiety, hypertension, and substance use disorders. We're in phase 1 of this competition right now, aiming to identify effective programs that increase access, attendance, and quality of care for postpartum visits for Black or African American and American Indian or Alaska Native beneficiaries enrolled in these programs. Submissions for this phase are due January 31st, and we encourage anyone interested or with questions to email postpartumchallenge@hhs.gov. Next slide, please. Great, so our next challenge is on endocrine disrupting chemicals. In this national competition, we're aiming to identify innovative programs that address the negative impact of EDCs, which can result in adverse health and reproductive outcomes. We're also in phase 1 of this challenge. We're aiming to identify and fund programs that demonstrate effectiveness, sustainability, and the ability to replicate and or expand interventions that address gaps in knowledge and provide actionable solutions to reduce EDC exposure for Black or African American women. You can see for both of these challenges, we have a firm focus on health equity, which is something our Assistant Secretary is particularly concerned about now. Submissions for this challenge are also due January 31st. We welcome you to email edcchallenge@hhs.gov with any questions. We really encourage everyone here to share with your networks. We'd like to award programs doing great work on these important subjects. I'm going to add some links in the chat here. We have a couple of webinars coming up today for the postpartum challenge and tomorrow for the EDC challenge. So please share with folks that you think would be interested in these challenges so we can get them on board. Great, so next slide, please. Great. So this next initiative I'm very excited about. It's a partnership with Premier and Mama's Voices. And we're focusing on improving maternal health data to advance health equity and creating a network of over 200 hospitals to deploy evidence-based best practices in maternity care. And I'll describe both of these prongs, the health data side and the collaborative side in equal measure. Next slide, please. Okay, so this is a multi-year partnership with Premier and Mama's Voices. So we have a healthcare improvement company on one side and a coalition of patient advocates as our partners. And with these partners, we're beginning a maternal infant health initiative to address maternal mortality and severe maternal morbidity through better data. And the idea that in order to improve maternal health, we need better data about women and babies. So for the data collection, analysis, and reporting prong, this first section here, we'll identify the key drivers of maternal infant mortality and morbidity, analyzing up-to-date and ongoing data. We're very excited about the timeliness of this data that describes the relationship between maternal and infant mortality. It's nationally representative from a standardized inpatient data and hospital discharge data platform. We'll go to the next slide. I'll describe what that data will look like. So this data will be a national baseline of maternal infant outcomes from 2008 to present. Like I said, it's ongoing data, so it will be updated regularly. It will explore and establish relationships between maternal and infant mortality, explore associations with important demographic variables, other conditions like age, race, ethnicity, cesarean rate, comorbidities, including obesity, hypertension, and diabetes, as well as other contributing conditions. We'll also look at cost analysis for maternal infant mortality and morbidity, the cost analysis for maternal infant mortality and morbidity, the impact by payer, hospital designation, and geographic region. And we'll create maps of severe maternal morbidity and mortality in the US to include racial, ethnic, geographic, and other disparities. So you can see it's not a small amount of variables. Next slide. We're also looking at COVID-19 impacts and how that impacts the outcomes for the maternal delivery population. We already have some results that we're seeing from the COVID-19 pandemic period, which by this definition is March to December 2020. So looking at the odds of in-hospital delivery-related mortality and severe maternal morbidity, we can see some pretty definite trends. So for the overall odds of in-hospital delivery-related death during this period, March to December 2020, the in-hospital delivery-related death odds were not statistically significantly higher compared to previous years, unless the patient had a COVID-19 diagnosis. Then the odds of in-hospital delivery-related death with the COVID-19 diagnosis were nearly 6 times higher than those without a diagnosis of COVID. And we see the same kind of trend for the overall odds of severe maternal morbidity during this period. Overall, SMM was 14% lower than previous years, which is great news. However, for patients with a COVID-19 diagnosis, SMM was more than 3 times greater than those without a COVID-19 diagnosis. So we can see that COVID is affecting the pregnant population. Overall, there has been an 11% annual decrease in odds of in-hospital death compared to the previous year overall. And prevalence rates of SMM also remained steady during the period studied. Next slide, please. Okay. So I'm excited to talk about our perinatal collaborative, which is the second prong, this 2-pronged approach. So we have the data side and then this collaborative side, where we work directly with hospitals to implement and analyze evidence-based interventions. And so I'll talk a little bit about the goals in this slide, and then in the next slide, I'll talk about how we're implementing those goals. So our goals are recruitment of at least 200 diverse birthing hospitals to join the perinatal collaborative, clearly defining areas of focus with overarching disparities considerations, individualized hospital performance improvement support to help drive the change, analysis of the direct impact of evidence-based interventions on maternal infant outcomes, measurements of the associations between maternal health and infant outcomes, and evaluation and analysis of the culture of safety in hospitals on health outcomes. Next slide, please. Great, so on this slide, I'll talk about how we're achieving those goals. This is a collaborative of hospitals and hospital systems. Like I said, it's a multi-year initiative. So we're working with these hospitals and health systems to create a culture and infrastructure to ensure the health of women and newborns by measuring outcomes, process, and implementation. So these strategies are aligning and augmenting national and state strategies. So we're working with the strategies that are already in place and aiming at three main measurable deliverables, which are also tools provided to hospitals. So these 3 main tools / deliverables are the perinatal collaborative outcome dashboard, measurable high reliability site assessment, that is both virtual site assessments and on-site assessments, as well as an individualized improvement roadmap. And so we have quite a range of tools that these hospitals have access to, and hospitals themselves are very intrigued and excited to get these tools. And we have to also mention our key partnerships with Mama's Voices and the National Birth Equity Collaborative. These are very important because they ensure patients' voices are heard, make sure that the initiative is patient-centered, and that care is equitable for all. Next slide, please. So this is a great map that shows the locations of our hospitals, broadly speaking. You can see in the little circles in the states of the number of hospitals in that state. And we have 220 diverse US hospitals in each of the 50 states and the District of Columbia now. And in those hospitals, we have over 500,000 births per year. So you can see we're not working with a small amount of data. We've got a nationwide collaborative here. Next slide, please. Okay, so here I'll talk just briefly about our 23 maternal infant areas of focus. And these outcomes are linking mothers and babies in outcome data. So we can see the impact of the health of the mother on the infant. And this is kind of groundbreaking because we haven't previously, no one has previously analyzed this kind of data at the national level. So we're excited to keep sharing this with you as we find new information. But just to give an example of what this will look like, and the first item on the list is hypertensive disorders of pregnancy. So we would see not just the effect on the woman, but the infant as well. For example, if the woman has preeclampsia, we would see the effect of that on the infant. So we can look at, for example, the effect of prematurity on diabetes, et cetera, et cetera. And so there are over 150 outcome measures that will be captured to understand the clinical and non-clinical factors that impact overall maternal health and infant health outcomes. Next slide, please. Okay, and just to sum up again, we have this two-pronged approach focusing on the data on one side, looking at data-driven insights, identifying the drivers of maternal morbidity and mortality. On the other side, we have the Perinatal Improvement Collaborative, implementing solutions and evidence-based care practices to make America the safest place to have a baby, which is our excellent tagline. And we hear it in the White House, and we're excited to be a part of this overall initiative. So thank you, everyone. I look forward to questions, and thanks.
Maggie, thank you very much. I appreciate it. Just one little aside, I would, since I'm sort of involved in making sure that we stay on time, I would like that the leads from the 3 work groups to kind of keep track of some of the potential recommendations, because I don't want to miss any. So we'll if you could help me do that for future reference, because a lot of things will come up in these conversations. And before I open it up, I just have one question, Chris. How does your collaborative align with HRSA's Alliance for Innovation and Maternal Health, their AIMM program, with both our hospital base? How do you align with that?
So we're working with HRSA, just making sure that we stay in lockstep with what we're trying to do and what they're trying to do. The hospital improvement programs, it's really based on what the hospital wants to do. So Premier helps the hospital focus on what the hospital is looking to do. So we really let them drive that aspect of it. And then at the federal level, we coordinate with HRSA as well.
All right, great. Steve, Calvin.
Yeah, I just had a quick question. So out of the 200 hospitals, it's helpful to have, they're probably all very large hospitals. That's how you get to the 500,000 births. But I would suggest it's still really important to look at the critical access hospitals and the others, how they fit into that network, because you don't want to ignore, even birth centers too. It's just a very small percentage. But anyway, the feeders into those systems, I think you just need to pay attention to those too.
Absolutely. And then the hospital recruitment, it was very important to us to focus on the diversity of the populations involved. So that was definitely a driving factor. But thank you for that feedback.
Janelle.
Thank you. My question was similar to Steve's question, just that making sure that this seems very similar to the California Maternity Quality Care Collaborative, CMQCC's work that they've done for a number of years, and knowing that they have included a number of different levels of hospitals. So I'm assuming that the hospitals that were invited to be selected were like level 0, level 3, between a level 0 and a level 3 hospital for this kind of care, or were they limited largely to level 1s to level 3s?
So I can't speak specifically to California, although I'm happy to take that question back to the team. But I know we've considered it pretty important to align with what the states are doing so we can coordinate with them, you know, in coordination rather than against. Yeah.
So I guess my question then would be that there's diversity in the size of the hospital. Or do you know if there's diversity in the size of the hospital, I guess?
There is. To what extent, I can't speak to that, but again, I'm happy to follow up with you.
Just because we have very rural states like Montana, and there are 5 hospitals selected from that very rural state. And like the Dakotas, I think there were 2 and 3 hospitals from one of the Dakotas or so. So knowing that those are pretty rural states and they don't have very many level 3 large center hospitals that have NICUs. So just the level of care that people are seeking, and knowing that Native women, Native American women tend not to deliver at level 3 hospitals. They tend to deliver at lower level hospitals. So I would expect that the diversity of population, if that's driving some of this work, then some of those smaller hospitals would probably be included as well. So I'm excited to see what happens, and what is the long-term, if you can in a sentence or 2, what is the long-term plan for after this this initiative, this collaborative? What are the plans to try to roll out and implement this nationwide?
Sure. So this is it's already a national level initiative. Do you mean beyond the hospitals that are in the collaborative now?
Yes.
Sure. So right now we're really focused on collecting and analyzing the data that we're getting now, and working on bringing the hospitals on board. That'll be part of the planning process. Looking at how this part goes, and then we'll plan for the next part. I'm sorry, I can't speak to the much longer term plan. But we're focused on the data analysis and the collaborative currently.
Thank you.
Thank you. Belinda.
And actually, my question was very similar to Janelle's. Trying to figure out the distribution of the hospitals. Are you looking at rural, urban, and the different sizes? So my other question then is there a list somewhere of all of the hospitals on your website or somewhere where people can see them if they're not what is happening in their own state?
Absolutely. There's a press release that went out recently. Let's see if I can dig that up. But yeah, absolutely. I'm not sure if it's on our website right now, but yeah, that information is absolutely available and we can share that.
If you have a link, you can put it in the chat.
Thanks.
Sure. Yeah, I don't have it right now, but I will find that for y'all.
And Magda.
Thanks so much. An exciting initiative. I think that this must have come from when you did all your listening sessions when you went around the country. When I think it's been a couple of years of building towards this. So thank you for putting national data out there. I'm going to push again on the question of, as you design this and move it forward, knowing that it is voluntary, knowing that you're getting the hospitals to opt in, what is the likelihood of linkages with other data that are national but speak locally of before and after the hospital experience, particularly the federally qualified health centers and other national databases within the purview of HHS? How does this data set that's emerging from 220 some hospitals align with and link with other MCH related data, one, and other sectors? If a hospital is looking at a concern about environmental exposures, or a concern with eviction in housing, or a concern with mental health. I'm just trying to figure out linkages as you not launch this. Are there receptor sites to connect it so that it tells a bigger picture? Particularly as you collect data on social determinants of health and health equity, your number 18 and 19. Great to see, but what does that mean and how does that link outside the hospital?
Absolutely. So we've recently finished bringing the hospitals on board for the collaborative, and we're working to kind of get them more on board and understand what they're looking for from the collaborative and that aspect of the project. I agree that would be a great benefit to be able to link, and we are in conversation with other folks at HHS, other agencies, making sure that we're working in lockstep. But yeah, those are conversations that are happening now. So we look forward to sharing more about that later on. But thank you for the feedback. That is absolutely important.
Belinda, did you have another question?
I did. I wanted to ask a question around the role of mama's voices with the program. So are they doing some qualitative support for the effort to actually listen to the voices of mothers in the process? I see that it's a collaboration, but and much of our questions have been focused on the hospital, but what is mama's voices role in it?
Sure. So they've been involved since the very early stages of this project. And we've touched base with them a number of times to update them on how the project is going and get their feedback on what's been done so far, and just asking, how can we make this project more patient-centered? And they've been great partners in this regard. Meeting with us, making their time available to us to ask for that feedback. They've given us a lot of great insights.
So then so is there like a requirement of those hospitals to have like a consumer engagement or, listen to individuals with lived experience as part of their work in this collaborative? I'm trying to see what the total connection is.
Sure. So we're still in part developing a lot of that aspect, but changing the culture of a hospital, as the hospital opts in, is an important part of this project as well. I'm not sure that I can speak to what each hospital will do, because again, it is a lot of it is very hospital driven. But we have brought Mama's Voices in at the key points in this process, if that helps.
I'm going to bring Kristen back in here. We got about 5 more minutes that will allow to broaden our conversation between the Office of Women's Health and CMS. And I'm curious with the White House action on Maternal Health Day of Action. I was just curious on how the recommendations from ACIMM were included or not included in that effort, and how the input that we've had on many of these issues was embedded into those conversations and putting that day together.
Sure. Are you speaking to specific recommendations for this project or general?
Generally with CMS and the Office of Women's Health.
Well, sure. So we work closely with CMS, and we've had folks, myself included, attending the ACIMM meetings. So we're aware of their recommendations and been taking them into account as we develop the program.
Good. Amanda, you had a question?
Yes. For both of our speakers. So fast forward 5 years, and your investment in this new hospital-driven system, voluntary system, or your data expansion and investments in Medicaid and CMS are there. What should we hope will be wild success? What does it look like? Not just the process of what you're doing, but could you just tell us what you really hope will change if what you're doing, what you've reported to us, is successful? And I just want to be caught up in your enthusiasm about what is possible to change because of the extraordinary efforts you're doing. And we can start with you, Meg, and then we can go back to Kristen. So you got it. It worked. Now what? What is now possible?
This is great.
I
love talking about long-term impacts. So again, with the two-pronged approach, the great success for the National Maternal Infant Analysis would be to identify the drivers of maternal mortality and morbidity. In that ideal scenario, we understand why women are dying, and we know what we need to do to reduce maternal morbidity and mortality. And then in terms of implementing solutions for the second prong, we have done that, and it has resulted in, America becoming the safest place to have a baby, to reduce the maternal morbidity and mortality rates, so that we are no longer the worst industrialized nation for maternal morbidity and mortality rates, but that we have improved those rates and women are safer and healthier as they give birth.
Okay. So once, if we data to action, that's helpful. Thank you. Kristen, do you want to respond? What success look like for your reporting today?
So success for us would be similar, would be starting to move that needle on maternal morbidity and mortality, and to see if, and as we work with states and as they develop their PDSA cycles and their small tests of change and figure out what works, if we're able to assist them and hopefully within the next 5 years be able to scale and spread that and identify those best practices and help disseminate that information to other states, to not only reduce the rates of maternal morbidity and mortality overall, but definitely chip away at those disparities as well. Because even if we lower it for all women, that would be, or all postpartum birthing people, that would be great. But if we still have those wide disparities, then we're still doing something wrong. So it would also be kind of looking at it through that equity lens and trying to reduce those disparities, along with moving the needle on hopefully getting more people into their postpartum care visits, connecting them with well woman care, connecting them with the specialists that they need, and making those infrastructure arrangements and working with states to develop this quality improvement infrastructure. So even when we're not doing monthly one-on-one TA with them, they're able to run those cycles themselves and make those changes and figure out how to improve those outcomes on their own. So that would be what success would look like for us.
Great. Well, thank you to both. We need to move on. So Kristen and Maggie, thank you very much for your presentations and for your responses to the questions. And I'm sure that if we have some other questions, we'll get back to you as we move forward. So thank you again for your time with us this morning or this afternoon.
Great.
We're going to take about 15 minutes because obviously COVID has influenced a lot of our work, and certainly a year ago when we spent a lot of time developing some recommendations related to COVID and its impact on birthing individuals and infants. And certainly here in Minnesota, where we're one of the top states now in terms of rates of infection, and we're reaching 800,000 deaths. I mean, it's still influencing a lot of our work and a lot of the work in the healthcare field. So I'd like to take just a little bit of time to see what have we learned over the last couple of years related to COVID, and are there things that we should be recommending in addition to what we recommended in June of 2020 that we really need to push forward. And I asked this in light of the fact that in October, the COVID Health Equity Task Force issued their report. And I read that report and I was impressed by the fact that I don't even think they mentioned pregnant individuals and infants. They talked a lot about equity, but pregnancy was not, and infant was not a big focus. They focused on things that we talked about in terms of workforce and facilities and vaccination and research and telehealth, but yet never really included pregnant individuals and infants in that. And it just really struck me, why not? And I would really ask Dr. Warren, we made some strong recommendations related to all of those things. Did they get advanced up to this task force in any way, shape, or form?
So the recommendations were submitted to the secretary. I can't speak. I mean, we could ask. I don't know whether those were sent to a White House task force or not.
Yeah, because it seemed like they were very specific, and there was really a miss, and an opportunity that really we should have somehow been able to take advantage of. But given that, even though that didn't happen, are there things that we should recommend now? Are there things that we should move forward from the committee members? What have we learned? You know, what are there gaps that still need to be addressed that we can play a role in?
You know, this is one big issue that I saw where I work in the Bay Area, that, you know, given that COVID is, it was a new infectious disease process that was happening that globally and on a short timeline, on a rapid timeline, I saw my team really flounder and fail. And it's because they had nothing like this ever in their experience. Nothing prepared them for what they had to encounter with a rapidly deteriorating birthing person and, you know, another rider alongside, you know, like two people together. So the birthing person and the fetus or the neonate, the infant. It was very, very challenging to see my team fail. They felt like they failed when we did the best that we could. We did not have the best counseling. We did not always have the best available studies to help guide the process. And we learned also that it's not just an OB related issue. It's in a hospital setting, it is a multidisciplinary issue when you have someone who's infected with COVID who is rapidly deteriorating and trying to make a decision of what's going to happen, what kind of care. Are you going to do a C-section on someone who is like 28 weeks to save one life, possibly not being able to save another? So it was really challenging just for the providers, not having, you know, definitely not having the guidance because a precedent like this had not been set. And so they're learning, everyone's learning as we go along, but also recognizing that people had to work together outside of their own little hallways. And that was something that we saw. So the ICU team, the hospitalists, had to work really hand in hand with the OBGYNs. And then this affected like our prenatal care and our postpartum care. So it was, such a situation unique to this population when we're looking at birthing people or pregnant people, that it really is not just looking at one segment of their care. It's looking at their whole care holistically. And so any kind of recommendation where for the future that we recommend that any kind of facilitation of multidisciplinary care or teamwork, or I think Paul Weiss brought this up a number of times, or maybe it was Paul Jarris, I'm sorry, but just that we didn't have a national plan in effect with the beginning of COVID. And it's going to take looking at a special set of team to actually care for pregnant people or birthing people in general.
Thanks, Janelle. Belinda.
I think one of the other areas we learned, which ties to what Janelle is saying, is around how we define the care team. You know, I think we quickly eliminated doulas from this process. We were telling moms that you can have one support person. So they have, many of them had a doula, their support person, but then they had to decide between whether their spouse, their good friend, their mother could go in, or their doula, because the doula wasn't considered part of the care team. So I think that is another recommendation, is that we need to make sure that how we are defining the care team, that this shouldn't just be the clinicians that work in the hospital. It's got to be who is supporting that individual during the prenatal and the delivery period. And I think that was a big miss for us in conversations that we're still having with hospitals and healthcare facilities. So I do think that was a miss, but I think it's a lesson learned as well.
Very good. Steve.
Yeah, I just wanted to second what Belinda said. I mean, Janelle's experience, I'm not currently, I'm past that point in my career of being in the hospital. So I totally understand, having heard what has been going on with the more acute care. But I would agree with Belinda that it's almost like the end of life and the beginning of life. During the pandemic, there were people who were unable to say goodbye to their dying relatives. And there are also people who mothers who are unable to have the support that they needed from doulas and family members. I think we just have to be more careful about it, because I've debriefed with a lot of mothers that I see with low-risk pregnancies who said, my experience in 2020 was horrific. I wouldn't have another baby unless I knew that I wouldn't be limited like that. I mean, it really became extremely restrictive. And I understand initially those restrictions, but we just have to be careful about those kinds of restrictions.
All right, thanks.
And along that line, Steve, like it's certain populations were targeted, right? Like I submitted the article, I think in last September as a snapshot of my presentation, but when we know that certain populations are have higher risk of having this disease, that certain populations were then targeted. So like in New Mexico, women were separated from their infants at a hospital. And who knows if policies like that also were enacted in other places. It's pretty understandable that possibly in the very beginning, when we knew very little, that those kinds of separations were happening. As Belinda pointed out, separating the dyad from breastfeeding, that also was happening, and to this day still happens in some places. So the understanding and trying to find, not criminalizing a population for their high rates because they're at more risk, right? And then also and then hospital policies that aim to keep the dyad together versus separate. Thank you.
Magda.
Your question, Ed, reminds me of the power of an after-action review. The ability to say there are systematic ways to look back, not just within the family, not just within the MCH world, but to find out where are the after-action reviews happening relative to the COVID response, because it's certainly not over. It's reinventing itself and morphing in new ways. So I will be curious from a quality improvement, from a hospital and other data perspective, where is this question being asked systematically in a way that women, children, families, fathers, birthing people are not an afterthought? And I think that's what we're seeing systematically, is that we were constantly in catch-up mode. We had recommendations, but it was like, oh yeah, pregnant women. Still now, oh yeah. And not being able to get ahead and always be in catch-up, whether that was in hospitalization, whether that's in vaccination. And I think that we have a duty to ask, where is the after-action review happening? And how can we put a standard set of questions and infuse that look back to look forward, which specifically can be the three key questions that every agency should be asking, every hospital should be asking, every health member should be asking. Say, what more could we have done and what will we do differently? So I think we have an opportunity to frame this, not only in this conversation, but as a tool to offer cross-sector going forward. Because if we don't ask that question, who else will?
Paul.
I guess my question would be, who, if anyone, has the responsibility and the authority to do such an after-action with regard to maternal child health? And Michael, maybe you know, but I think given our very federated system, it's not clear who that would be. I don't think anyone has the ultimate responsibility, but who would have the authority to step up if they want to take the initiative?
And I want to add to that before Dr. Warren responds, is there something that we could still do to move forward those recommendations, getting the ones that we've already made and in additional things that we have to the Health Equity Task Force, COVID Health Equity Task Force, so that actually all of our work can actually be put into action? So 2 questions. And is there still something we can do proactively? And then who will do that after action response? And then we'll move on to our next topic.
I'll start with the second part of that. I think certainly if the committee would like those forwarded, your recommendations were to the secretary. If the committee wanted to request that the department consider moving those forward, we could certainly pass that along to the office of the secretary. I think in regards to your first question around the after action review, it depends on the scope, right? In terms of who would do it, who would be best poised to do it. So I think figuring out what's the what is the exact question? Are there particular aspects that you're interested in thinking about? That may help hone down who would be best to do that, and whether does that make sense for a government entity? Who would have the authority, or is that a non-government entity? But I think getting a better handle around the scope of it would be a first step.
Mm-hmm.
All right. Well, and
go
ahead,
Michael. Are you aware of the locus of accountability? And Maternal and Child Health Bureau has often been called, I think this is a bit of Touchland's line, the locus of accountability for the health of all women, children, and families in the nation. So if there's appetite, this could be something that SACIMM can be helpful about, given that this is not the last pandemic or emergency. I think this is an opportunity not for blame and shame and pointing fingers, but again, lessons learned, not to have history repeat. And so I'm curious if MCHB sees itself as that locus of accountability, because that's what we're talking about, accountability, not in addition to authority, Paul, for the well-being of pregnant people and infants at a start.
I mean, certainly our mission is broad. I think when you think about the various facets of the emergency response across the pandemic, that is far bigger than MCHB. And frankly, it's far bigger than the federal government. And so I think thinking through what the specific questions are and whether that's us, whether that's a sister federal agency, whether that's someone else, it'd be helpful. Happy to continue to think through that, but also want to know better what the what is before we say yes or no.
Yeah. So Dr. Warren, let me follow up with you after this meeting on both of those issues, on an after action thing, but also how do we move our previous recommendations, remove them again to make them as engaged with the process as possible. So I'd like to be able to move on both of those. And speaking of movement, let's move on to our next topic, which I think is also going to be very interesting. Birth defects and congenital anomalies, as you know, are a leading cause of infant death. So we are going to take this next session and really focus on that. And I've asked Tara Sander-Lee, one of our members, to coordinate and moderate the session. So Tara, I'm going to turn it over to you.
Thanks so much, Ed. Yes, I'm very excited for this session. Thank you for the opportunity so that we can discuss this. So I just want to give just some really quick brief remarks just so that we can stay on track with timing. According to the CDC, which you'll hear from our first speaker, birth defects are the leading cause of infant deaths, and it affects approximately 1 in every 33 live births, or about 3% in the United States each year, and accounting for 20% of all infant deaths. So it's so important that we have this discussion today, that we are presented with the most up-to-date data and information as we move forward, perhaps with making recommendations. Our second speaker is going to discuss how we can actually treat some of these birth defects once they are diagnosed inside the womb, before these babies are born. And this is this incredibly new and exciting field, and scientific evidence proves this effectiveness in providing some of these interventions for these women and their children in reducing infant deaths. And almost monthly, we hear in the news about another baby diagnosed inside the womb with disorders such as spina bifida that receive life-saving fetal surgery, or babies diagnosed with twin-to-twin transfusion syndrome that both survived after given the chance of life with advanced medical techniques. So as part of our quality and access to care work group, we have been discussing ways in which women can have better access to prenatal fetal therapies and interventional care to decrease infant mortality. Also better diagnostics to have better fetal monitoring, perinatal fetal monitoring. And so we also know that not all women who face a poor prenatal diagnosis are aware or even have access to the type of medical treatment that is needed and care that is needed to prevent some of these deaths. And not all women are given the option or do not feel that they have the resources needed to accept the option of fetal therapy when offered. So for example, there's barriers such as access to care itself, also access to childcare for their other children, financial constraints, relocation, loss of work time. So, and this is an exciting and relatively new field when we talk about fetal therapy. So additional research is also needed to determine medical necessity and identify maternal fetal risks associated with fetal therapy procedures, as well as improved reporting of outcomes. So it's a big field. I think it's important to start this discussion today. I thank you. And so I'm going to introduce our first speaker, which is Dr. Naomi Tepper, Captain of the U.S. Public Health Service, Senior Medical Officer, Birth Defects Monitoring and Research Branch for the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. So thank you, Dr. Tepper, and we're looking forward to your talk.
Great, thank you, Dr. Lee. Can you hear me okay?
Yes, we can hear you just fine.
Okay, terrific. Thank you so much. Good afternoon and good morning to some of you. As Dr. Lee mentioned, I'm an obstetrician gynecologist at CDC. I'm in the National Center on Birth Defects and Developmental Disabilities, and I'm really honored today to represent our center at this meeting. I'm representing on behalf of our center's committee members, Drs. Karen Remley and Dr. Cheryl Broussard, who you all probably know and who are unable to attend today. And we were asked to share with you some thoughts on the impact of birth defects on infant mortality and some potential opportunities for improving outcomes. Next slide, please. So I wanted to give a little context for the contribution of birth defects to infant deaths. And as you just heard, birth defects are the cause of approximately 1 in 5 infant deaths. Next slide, please. This table shows data from CDC's National Center for Health Statistics on the leading causes of infant deaths in the US in 2019. As you can see in the first row, congenital malformations, deformations, and chromosomal abnormalities, which is basically the ICD-10 coding terminology. These were the leading causes of infant mortality. There were approximately 4,300 infant deaths in which congenital malformations were listed as the cause of death. This represented 20.6% of infant deaths and a mortality rate of 114.8 per 100,000 live births. Next slide, please. The causes of infant death are not uniform throughout the first year of life, however. Congenital anomalies are the second leading cause of death in the neonatal period, which is less than 28 days of life, and are the leading cause of death in the post-neonatal period, 28 days of life through 11 months. Next slide, please. This graph shows mortality rate by race and ethnicity in 2018. And as you can see, there are differences in mortality rate by race ethnicity, with the highest rates in non-Hispanic Black, American Indian or Alaska Native, and Hispanic infants, all higher than the rate in white infants. Next slide, please. This figure shows trends from 2003 to 2017 overall and by race ethnicity. From 2003 to 2017, rates of infant mortality attributable to birth defects actually declined, which is what you can see in the solid blue line. However, even with the overall decline, racial and ethnic disparities remain. And this figure shows that deaths among Black and Hispanic infants, which are the top 2 lines, are higher than white infants, which is the bottom line. Next slide, please. This analysis was published by members of my branch at CDC, and they offered some thoughts on the reasons for the overall decline as well as the disparities. The declines could be due to improvements in prenatal care, implementation of birth defect prevention measures, and improvements in medical care of infants born with birth defects. The disparities, however, may be influenced by differences in access to and utilization of healthcare, both before and during pregnancy, differences in frequency of prenatal screening, differential losses and terminations of pregnancies with fetal anomalies, and different insurance types. Next slide, please. My colleagues also looked at insurance coverage and found that infant mortality among infants with birth defects differs by payment source for delivery. So this graph shows the mortality rate among deliveries covered by private insurance, which are in the light purple bars, and Medicaid, which are the darker purple bars. As you can see, mortality rate is higher among deliveries covered by Medicaid than private insurance. And this is found overall and when stratified by gestational age at birth, maternal race and ethnicity, and maternal age. The authors' theories were that this may be due to some of the differences that I mentioned on the previous slide, differences in health status, access to and utilization of healthcare, differences in prenatal screening, and differences in terminations for fetal anomalies. Next slide, please. From that same report, the most common birth defects associated with infant mortality were central nervous system defects, congenital heart defects, and chromosomal abnormalities. These three categories of birth defects contribute to 57% of neonatal and 76% of post-neonatal mortality among infants with birth defects. Next slide, please. So in thinking about where there may be opportunities to improve outcomes related to birth defects, I thought about it in terms of 4 realms of activities, including surveillance, research, prevention, and treatment. I will share some thoughts and some of CDC's work in these realms, although particularly the area of treatment is addressed more comprehensively by other agencies and organizations. Next slide, please. So we have to conduct surveillance to understand the scope of the issue. Next slide. Surveillance for birth defects is going on in many states, several of which are funded by CDC. These surveillance efforts can provide information that is critical to inform the understanding of trends in birth defects, the conduct of research on risk factors, planning and evaluation of prevention activities, ensuring that affected babies and families are referred to appropriate services, and assisting states in allocating their resources and services. Next slide, please. However, our surveillance is only as good as the data we collect. This graphic shows what CDC is working toward in terms of managing public health data. We know that current data systems can be slow, outdated, resource intensive, and not very user-friendly. We are working to modernize our data systems to make data more timely, accurate, and accessible. In an ideal world, we would have a national birth defect surveillance system where data was available in real time and could be linked between systems and states and could be analyzed quickly to inform next steps. Even if we can't reach that ideal world, investing in improvements in data systems could have a huge impact on our ability to gather and use public health data. Next slide. Turning to research as an opportunity. Next slide, please. Research is clearly important to further understanding the causes of birth defects. Within our center, we coordinate several multi-state studies to examine the causes and risk factors of birth defects. There have been many important findings from these studies, which have been used to inform clinical practice, confirm previously observed associations, generate hypotheses for future study, identify areas for prevention, and provide information to the public. Next slide, please. These are the birth defects included in our currently ongoing study called BD STEPS. And BD STEPS is really aiming to study risk factors that may be modifiable, such as medical conditions, medications, and other exposures. So we hope that the findings can be used to move the needle on reducing preventable birth defects. Next slide, please. Ideally, we would prevent birth defects before they occur, but unfortunately, there is still a lot that is not known about preventable causes of birth defects. Next slide, please. There are some challenges in preventing birth defects. Most develop during the first trimester, often before pregnancy is recognized. The cause of the majority of birth defects is still unknown. And the study of modifiable risk factors is difficult due to challenges in case ascertainment, case classification, exposure assessment, particularly potentially multiple exposures, and statistical power to detect associations. Next slide, please. However, there are certain modifiable risk factors that we do understand and for which we can make an impact on the incidence of birth defects. For example, promoting optimal folic acid to prevent spina bifida and controlling diabetes to prevent several birth defects, including congenital heart defects. Next slide, please. And finally, I wanted to mention treatment, which may impact survival and also may impact the quality of life for individuals living with birth defects. Next slide, please. First, we have to identify affected infants. Newborn screening identifies infants at risk for congenital disorders for which early intervention has been shown to improve outcomes. The number of disorders in the recommended uniform screening panel is now 35. Hearing loss and critical congenital heart defects are detected through point of care screening, and 33 other disorders are detected through dried blood spots. Newborn screening is estimated to identify almost 13,000 infants with one of these disorders each year. Next slide, please. As an example, early detection of congenital heart defects leads to improved survival. Some of my colleagues who focus on congenital heart defects found that survival of infants with critical congenital heart defects has been improving. Newborn screening for critical congenital heart defects through pulse oximetry was added to the recommended uniform screening panel in 2011. This screening decreases early infant death by 33%, preventing 120 early infant deaths per year. Although all states are screening for critical congenital heart defects, not all states are systematically collecting and analyzing their data on the timing and mode of detection. Systematic data collection could help identify program improvement opportunities and monitor the impact of early identification of critical congenital heart defects. Next slide, please. Another example of looking at treatment to improve outcomes is the UMPIRE protocol. UMPIRE stands for Urologic Management to Preserve Initial Renal Function Protocol for Young Children with Spina Bifida. My CDC colleagues and experts in the field developed this protocol in which infants up to 3 months old with myelomeningocele are identified, monitored, and treated using this protocol. The goal is to use this standardized protocol to identify early problems with bladder and kidney function and intervene to help preserve function. Continued assessment of this protocol is leading to improvements in the protocol and improvements in outcomes for infants. Next slide, please. I won't spend a lot of time on this because our next speaker will be discussing this further, but fetal surgery, as mentioned, involves surgical intervention for conditions with poor prognosis, such as those listed here on the slide. This field has been expanding rapidly and can lead to improvement in fetal outcomes. However, these surgeries are very complex and require specialized centers with multidisciplinary teams. They can also result in adverse outcomes for the pregnancy and the mother. Ongoing research is looking at whether and how these surgeries improve outcomes. Next slide, please. So this is kind of a summary slide of the preceding slides and with some general thoughts on the opportunities to improve outcomes. In the realm of surveillance, we can continue work on modernizing our data collection and management to make data more timely, accurate, and accessible. In the realm of research, we need to further understanding causes and risk factors of birth defects, particularly those that are modifiable, so that we can inform prevention, treatment, and future research. In the realm of prevention, we can use what we know about preventable birth defects and work to ensure that all people of reproductive age have access to quality preconception and prenatal care. And in the realm of treatment, we can continue research on and access to surgical intervention and quality care initiatives. Next slide, please. I just wanted to finish by sharing CDC's agency-wide strategy to integrate health equity into all of our work. And of particular relevance to this discussion, we've seen there are health disparities in infant mortality related to birth defects. CDC is committed to working to better understand and address these health disparities as a key part of impacting health outcomes. Next slide. I think this is my last slide. I really appreciate the opportunity to talk with you today. I'd like to thank my CDC colleagues and our many collaborators who are doing the work that I shared. I thank you very much, and I'm happy to try to answer any questions. Thank you.
Thank you so much, Dr. Tepper. That was fantastic. I think we do have a couple of minutes. So if people do have some questions, I think if you don't mind, can you stop sharing your slides? Maybe we have a couple of minutes. So do we have some questions for Dr. Tepper? Yes, Janelle.
Thank you. Thank you so much for that presentation. I was struck with one of the very first slides you shared. It was the rates of infant mortality attributable to birth defects from 2018. And it showed African American and American Indian, Alaskan Native infants had really high rates. And then subsequent slides you shared, and it was likely data, surveillance data from the CDC, that the American Indian population just fell off. We have no historical rates of birth defects that were included in these larger studies from 2003 onward. And so I'm just wondering, can you comment on the missing data for this population, and why not pull from Indian Health Service as a potential data source for, just including historical data? And then the second part would be, how do you propose that adequate surveillance in the time of health equity for this population will be met? Thank you so much.
Yes, thank you for those questions. Yeah, the differences in rates are really striking and certainly concerning. The data that I showed comes from the National Vital Statistics data, and I pulled from different reports. And so the one where I showed the trend lines that does not have the American Indian and Alaska Native population is just because in that report, they did not report on that. However, that data is likely available. I couldn't tell you right offhand how far back that's available, but that data is available by race, ethnicity for infant mortality and causes of infant mortality. So we do certainly have that, and I think we need to dive more into that, but looking at the differences as well as the reasons why. And a lot of the reasons are probably not captured in the data, unfortunately.
Danielle.
Hi, I just wanted to follow up a little bit on that. I was on that MMWR paper that you presented. And so one of the reasons we did not include American Indian or Alaska Native is simply because even though the rates are very high, in that report to break it down the way you would need to by groups, the numbers become so small that unfortunately they are unreliable. So in a lot of the research that we put out, it's very difficult to include some of the race and Hispanic origin groups simply because we're not combining years together. I did want to point out that we do have the mortality rates for congenital malformations in the annual infant mortality report that we put out. I noticed that you had 2018 data in the presentation by race and Hispanic origin. We did just release the 2019 last week, so obviously you wouldn't have had time to include that. I did include a link in that in the chat.
Wonderful, thank you so much. Ed.
I'm just wondering if you're having any specific activities related to sickle cell. I know it took us a long time in Minnesota to screen for sickle cell. I don't know how many states are doing that. Any special efforts related to sickle cell anemia?
Yeah, well, that's a great question that I would actually have to defer to other CDC colleagues. We have a division within our center, the Division of Blood Disorders, actually focuses on, among others, sickle cell disease, and they have been, very interested in certainly increasing the diagnoses and the care of these individuals, both for infants and through the lifespan. So increasing recognition of challenges that these individuals face throughout their lifespan. And so I think if there are specific questions about sickle cell, I'm happy to take them back to that group. They are working hard and do a lot of great work. So I'm happy to communicate anything back to them.
It's just a good example of some of the inequities in newborn screening that have been there. And I think that it's a good case study on way we've disadvantaged some populations over others.
All right, thank you so much. Okay, I think if there's no other questions, we're going to move on to our second speaker. So our second speaker is Dr. Julie Moldenhauer. She is the Director of Obstetrical Services and George Lieb Harrison Endowed Chair in Fetal Therapy at the Center for Fetal Diagnosis and Treatment. She is also the Children's Hospital of Philadelphia Director of the Division of Obstetrics and Gynecology and Professor of Clinical Obstetrics and Gynecology and Surgery at the Perelman School of Medicine at the University of Pennsylvania. So thank you, Dr. Moldenhauer, for joining us today and taking time out of your busy schedule to present.
Oh, well, thank you so much for having me today and letting me present on something that's pretty near and dear to my heart. And I'm hoping that by the end of this, I'm going to convince you all that this is not science fiction, but that this is something that is a reasonable treatment option for patients in certain scenarios. Next slide, please. So what exactly is fetal therapy is a common question that we get. And so, in a nutshell, it's pretty much any intervention that is performed on the maternal fetal dyad specifically for the benefit of the fetus. And so in this context, the mom is accepting the risk. And, we sometimes think of the mom as the innocent bystander in this dyad. And we are a relatively new field. We've really only been around for about 60 years. And if you kind of think about the disorders that we treat, some people use the term orphan disorders, but we're really not truly orphans, but we are in the context of, we don't really have like a governing board. There's not, the American Board of Fetal Therapy type of thing. And so it's really multidisciplinary. It's groups of people from surgery, maternal fetal medicine, obstetrics, anesthesia, all the pediatric subspecialties, cardiology who come together to make fetal therapy work and to make it safe for mom and baby. Next slide, please. I would be remiss in talking about fetal therapy if I don't talk about the diagnostic aspect of it. And again, this is sort of where we are such a neophyte in terms of when we started. The first publication that had anything to do with making a diagnosis in obstetrics and gynecology was in 1958. And these images are true to the word of what they saw. This was a fetal head, basically. And so imaging was quite poor. Next slide, please. And things move fairly quickly as far as our ability to diagnose various disorders prenatally. So spina bifida, anencephaly, we could do that by, the 70s. We were screening for open neural tube defects throughout the 70s and 80s and Down syndrome into the 80s. And then, cell-free DNA, fetal DNA in 2000s. And I put these, images below because looking back to the image that we saw of what basically looked like black and white schmutz, we have come a long way. We can use 3D, 4D, ultrasound, we can use MRI, we can use CT scanning to make diagnoses. And so in this sequence of events that has come for our ability to make a good diagnosis in utero of various fetal findings, we then can apply our ability to treat those findings in utero and hopefully impact, mortality and morbidity. Next slide, please. So, kind of looking on the flip side of things, the diagnostic aspect is on the top side of the timeline, and where we are coming as far as fetal intervention is underneath. And so shortly after we saw the first publication for ultrasound in OB, the first intrauterine blood transfusion was performed in 1961 for Rh disease. We were doing diagnostic fetoscopy. So literally, if you have a, cholecystectomy and they do it through laparoscopy, in this instance, the scope is going inside the uterus to look inside the amniotic cavity and make a diagnosis in the fetus. And so we could do that, and we could do it relatively safely as far back as the 70s and 80s. Things really exploded on the fetal therapy scene in the early 80s to 90s, where we developed animal models. We really expanded what we were doing from a fetal therapy standpoint. And things included not only open fetal surgeries, but minimally invasive surgeries that were done under ultrasound guidance. Then we kind of crossed over into twin therapies because it before that had always sort of been taboo to do fetal therapy when there was more than one fetus present. And that takes us up to where we are in the 2000s, where, probably what most people are familiar with is the management of myelomeningocele trial that started in 2002, but there was about a decade of work that happened before that trial even got kicked off, and it took us almost a decade to finish it. That was published in 2011. And since really the early 2000s, the number of fetal centers have grown exponentially. And they're more situated throughout the country, but it also dilutes the experience that each fetal center has when you have so many. Next slide. This is really just sort of a depiction showing the variety of things that we can take care of from, in the upper left, that's a shunt in a fetal chest as the baby's being born for lung lesions. The placenta and the twins are for twin-twin transfusion syndrome. The middle row is open fetal surgery for a lung lesion. The two next to that are sacrococcygeal teratoma, debulking in utero, and then what the baby would look like if they were born without the surgery in the middle row on the right. And the bottom row is open fetal surgery for myelomeningocele. The middle picture is an exit procedure for a fetus that has a airway compromise. And then on the bottom right is what the gravid uterus looks like when we are operating on them. So it's a quite a scene to be in the operating room. Next slide. Historically, the conditions that we've treated with fetal therapy have been those that are life-limiting or lethal, but particularly with the publication of the MOMS trial, the paradigm is really shifting to improving the quality of life as well. Next slide. There are some tenets that we use to help guide us decide who's a candidate, who's not a candidate, what are the prerequisites. And, hands down, we have to be able to make an accurate diagnosis prenatally. We need to know what the natural history is and how can we impact that so that we are, avoiding the potential for fetal death or organ destruction. And can we do it? And can we do it reliably and repetitively in the same safe manner? Next slide. Conditions that we can treat, range anywhere from fetal cardiac arrhythmia that we treat with mom, with placental pharmacotherapy, where we just give mom a medication. It goes through the placenta and treats the fetus, all the way to the, more invasive procedures like fetoscopy or ultrasound guided procedures. And then, the most invasive end of things, where we are doing open fetal surgeries and exit procedures. Next slide. This just gives a synopsis, sort of what it is when we're looking at what the anatomic defect is, and what it leads to from a physiologic standpoint. So when a fetus has a genitourinary obstruction, they don't have amniotic fluid circulating, and it results in pulmonary hypoplasia and renal dysfunction. Twins who have vascular anastomoses on their placenta develop twin-twin transfusion syndrome in 10 to 15% of cases, and this can ultimately lead to fetal death. Diaphragmatic hernia, which I'll also talk about, results in pulmonary hypoplasia that in many cases can be lethal. Lung lesions, such as cystic adenomatoid malformation, can also lead to high output cardiac failure, high drops in fetal death. The same thing with sacrococcygeal teratoma. And the myelomeningocele is sort of the game changer, where it's not just a life or death situation, but the goal of the fetal therapy is that we can intervene and try to minimize some of the side effects, like the hydrocephaly, paraplegia, and incontinence issues. Next slide. I kind of hit on this already, that we have a wide range of interventions that come from minimally invasive to the more significantly invasive. And next slide. This really impacts, what the risk factors are, both for mom and baby. And so, the list is long, and it can not only impact the current pregnancy for mom, but also subsequent pregnancies, because a lot of times things that we do require that, mom have a cesarean delivery with this pregnancy and in every future pregnancy. And it puts the future pregnancies at risk for having poor outcomes that could be related to uterine rupture. And then there's always the possibility that, we could have a fetal death or loss, or that what we're trying to do may not be successful, or we could cause more injury than good. And so we always have to weigh the risks and benefits, both for mom and for baby. It's not in most fields, there aren't two patients in one, which is, kind of what we are dealing with on an everyday basis, trying to weigh the risks and, balances both ways for mom and baby. Next slide. Now, I don't want to be Debbie Downer, because despite the risks, there are benefits. Some of the key tenets that we have to live by is that, the benefits are there when we are choosing appropriate candidates. And so, for the procedures that we do, there are fairly well-defined criteria for who would be a candidate versus who would not be a candidate. Experience does matter. So it matters in the ability to make the diagnosis, and to have a team who has the technical ability to perform the procedure safely, and with, outcomes that are reproducible. And centers who do this also need to have representation from all the various disciplines that are involved. It truly takes a village in this case. And then the maternal informed consent is also a huge part of the process. So not only does the patient need to understand what the risks and benefits are in the the current pregnancy, but as well in the future pregnancies that she may want to carry. And then also, what are the limitations with the fetal therapy? Because many of the things that we do are not necessarily a cure-all in utero, but they're to temporize so that we can, get the baby to be live born, and then there's still issues that we'll have to deal with after the baby is here. Next slide. So I wanted to kind of talk about some of the more common things that we see to provide an understanding of the impact that we can have. So complicated monochorionic twins are one of the biggest diagnostic groups that we see. And so, the majority of twins are dichorionic, meaning they each have their own placenta. But depending on when that fertilized egg separates into twins, determines geographically how things are arranged on the inside. And so if it separates after the first 4 days, we have monochorionic placentation, so twins who share a placenta. And then whether or not they're diamniotic, they each have their own sac, or monoamniotic, depends again when they split, whether that's, after 8 days or not. Next slide. And so the problem is when they share a placenta is that there's typically some unequal sharing. One generally has a larger share of the placenta than the other, but there's also, by definition, vascular connections between the twins. So whether these are artery-artery, artery-vein, vein-vein type of thing, this can ultimately result in imbalance in those anastomoses and unequal sharing of the placenta that can lead to the complications that we see. And the inferior picture is actually a picture that we took during a laser for twin-twin, and it shows the two ends of the vessels from each different twin coming together and creating an anastomosis. Next picture. And so twin-twin transfusion syndrome complicates about 10 to 15% of monochorionic twins. And what the resultant physiology is that there's a donor who is pumping blood to the co-twin, who is the recipient, and it basically results in the donor twin working very hard and becoming the fetal equivalent of dehydrated. So there's less amniotic fluid in that sac. They do tend to be the smaller twin. And then the recipient has to manage all this extra volume that is coming on board. And they do this by, having higher levels of amniotic fluid because they're trying to get rid of all that excess volume. It stresses the heart to have to pump all of this blood volume through, and so they can have cardiac failure. And in this process, they can develop all-out cardiac failure, and it puts both babies at risk for passing away on the inside. Next slide. And so, what is the impact of twin-twin transfusion? So in the States, it's about 6,000 babies a year who are impacted. And for twin-twin that's diagnosed less than 28 weeks, the overall survival is only about 10 to 30% when twins are not managed aggressively. So we do stage twin-twin, and for the sake of time, I won't go into that. But for twins who have advanced stage twin-twin, with this low survival rate, somewhere around 10 to 30%, there's also a high risk for neurologic morbidity because of these vascular connections. Next slide. And so how we treat this is through fetoscopic laser photocoagulation, where the scope is literally placed through a small incision on mom's abdomen. It's about 2 to 3 millimeters. The scope is quite long so that we can visualize what we need to see, but we're looking at the surface of the placenta, and everywhere that we see that there's an anastomosis between the two, we fire the laser. And so what firing the laser does basically is it spot welds those blood vessel connections shut so that there's no longer communication between the twins, and it functionally separates their placental shares. And we basically do this down the vascular equator between the two. And you can see how we're now flipping the statistics about survival. And so the likelihood that we will have twins survive to a reasonable gestational age where they can become viable and have a reasonable outcome is about 70%, and singletons is at least 80%. This is sort of the national statistical data. Some centers have higher outcomes, some centers have lower outcomes, but this is sort of where we are on an average. Next slide. Another diagnosis where we can make an impact is with congenital diaphragmatic hernia. In the States, this is about 1,600 babies per year, or 1 in 3,000 births. And what this is a defect in the diaphragm that allows the contents from the abdomen basically to grow up and develop in the chest. And so it pushes the normal lung to the side and results in severe pulmonary hypoplasia. And as a result, the lung that does develop is not exactly normal, so there's pulmonary hypertension. These kids spend a very long time in the NICU after they're born. They're almost always on ventilator support, and depending on the severity of the diaphragmatic hernia, they may actually require ECMO as well. And then part of this is, if I'm really hypoxic early on and I spend a long time in the NICU, developmental delay and feeding issues also become a part of my outcome. In the grand scheme of things, about 80% are left-sided and about 20% are right-sided. And if you look at the overall survival rate among all diaphragmatic hernias, it's improved. It used to be about 50%, but unfortunately we're only up to about 70%. Next slide. And so tracheal occlusion was developed because what we saw in different tracheal obstructive disorders is that fetuses would have very large lungs. And so this has been tried as fetal therapy to improve lung development in cases of diaphragmatic hernia. And so the current method that we use is fetoscopic endoluminal tracheal occlusion, or FETO. And under ultrasound guidance, again, a fetoscope is advanced into the fetal mouth, because once we get the scope inside, we can see where we're going. And so we directly visualize the fetal face. The scope goes into the fetal mouth, through the vocal cords, down into the trachea, and a tiny balloon is placed. And the balloon, before it's blown up, it literally looks like a piece of long grain rice. It's really, really tiny. We put this in between about 27 and 29 weeks. The balloon is deployed, and then it stays in the trachea until about 34 weeks. And the goal is that it obstructs the trachea, and all the fluid that is normally coming from the lungs gets trapped, and then all that stretching results in fetal lung growth. Next slide. And then the goal is that we keep the balloon in place until about 34 weeks, and then we go back in and basically do the opposite, and we take the balloon out. And the pictures show looking directly at the vocal cords of a fetus. That's what the top picture is. And then the picture below is the tip of the balloon placed inside the trachea. And then on either side of that circle where the image is, those are the actual fetal vocal cords. So we go through the vocal cords to deploy the balloon. And then once the balloon comes out, the goal is that we keep mom pregnant till at least term, so 37 weeks and beyond, and hopefully impact the outcomes. Next slide. So Jan Deprest, who's our colleague in Europe, who's been working on FETO for years, recently just finalized the total trial, looking specifically at the group of left-sided diaphragmatic hernias that are in the severe range, where the survival is less than 25%. And in this randomized trial, there was definitely an improvement in survival for the group that had FETO. So 40% of these kids compared to 15% for the expectant management group survived. And they survived not only to hospital discharge, but for the first 6 months of life. We didn't see the same benefit with moderate severity left CDH. And so we're not doing that. It's not been really adopted for that group yet. But we, in our series of FETO patients, have also seen a decreased need for ECMO, a shorter hospital stay, and some other improvements with the degree of pulmonary hypoplasia or hypertension that they have. So it's probably going to pan out that there's going to, be a tremendous impact not only on mortality for these kids, but also some of the morbidities they experience in the first year of life. Next slide. And then myelomeningocele, which is a form of spina bifida, often considered to be the most severe form, impacts about 1,500 babies a year here in the States. And this, having the presence of MMC, results in severe hydrocephalus that requires a shunt, hindbrain herniation, and then neuromuscular disorders that can include weakness, paralysis, and incontinence. Next slide. And the rationale for doing fetal surgery is that if we can intervene and do the same basic closure of the MMC before a baby's born, that we can reverse some of the damage that we see that happens throughout the course of the gestation. And so closing the defect, creating a watertight closure, can prevent further damage to the nerves that innervate the bowel, the bladder, the lower extremities, as well as improve the hindbrain herniation and decrease the need for fetal shunting. Next slide. And so this is a pretty big surgery for mom. So currently the adopted kind of gold standard for fetal myelomeningocele surgery is open maternal fetal surgery, although fetoscopic techniques are being developed. And so the picture on the left is a depiction of mom, sort of where we make the laparotomy. It's about halfway between the pubic bone and the belly button. We use ultrasound to map the placenta in the fetal position. And then in an area free of fetal parts, placenta, umbilical cord, stay sutures are placed to enter the uterus, and then a uterine stapling device creates the uterine incision, and it basically cuts and staples at the same time, so it's a bloodless incision on the uterus. Next slide. I know these are a little bit graphic, but what happens then is that the repair is done very similarly to what happens when babies are, 24 hours old. And so the neural tube defect is basically incised with care being taken to, not damage any of the nerves that are there, or any of the spinal cord that is there. Next slide. And then the myofascial flaps, so the muscle on either side of the vertebrae spinal cord are sort of freed up so that they can be brought over the top of the nerve tissue and then closed over the top of it in a watertight fashion to protect whatever nerve tissue is there so that we can optimize the function in that. Next slide. And then this is what the baby's back looks like after it is closed. It just looks like, a running layer of suture in the skin. Next slide. And so in the MOMS trial, where patients were randomized to either have prenatal closure or routine postnatal closure, there's a whole lot of data on this slide, but next slide is the nuts and bolts. So the biggest things are that, the risk of needing a ventriculoperitoneal shunt placed was basically cut in half. So for the group that had postnatal surgery, it was around 80%, and the prenatal group, it was 40%. There was an improvement in motor function for the prenatal surgery group. A large majority of patients who had prenatal surgery had reversal of the hindbrain herniation, and you were twice as likely to be an independent ambulator in prenatal surgery compared to postnatal surgery. Next slide. Now, there are a lot of risks that went along with this. There's a large proportion of babies that were born preterm. There's a lot of preterm labor, membrane rupture, and membrane complications. And so, again, it's risk benefit and trying to sort out where we are and what parents, what families can tolerate. Next slide. One of the big questions that came out shortly after the MOMS trial is, okay, these procedures were done at 3 centers in the trial. Is this data reproducible and applicable to the general population? And if this becomes, a procedure that's done across the country, and the North American Fetal Therapy Network sponsors the Fetal Myomeningeal Consortium and created a registry. I'm the PI on it. And we track outcomes for any center that's willing to participate. And we presented at the Society for Maternal Fetal Medicine in 2019 our outcomes on the initial approximately 500 patients. And the bottom line is that this collaborative effort showed that in real world, medicine and real world fetal therapy outside of a trial, that we could reproduce outcomes very similar to a randomized trial. Next slide. But the big question is, are there disparities in fetal intervention? And I think using the fetal myomeningeal closure statistics is probably the most straightforward and probably what we have the most data on. You can see here, looking at the MOMS trial breakdown of race and ethnicity, the middle row is our data here at CHOP on our 300 cases we've done since the MOMS trial. And then the Fetal Myomeningeal Consortium registry that has over 1,000 patients in it. Overwhelmingly, the patients are white non-Hispanic. The other groups are much less represented, as you can see, and the breakdown is different depending on how the data is collected. But the educational background tends to also follow with this as well. Next slide. Now, the irony here is that if you look at the prevalence of spina bifida, Hispanic women are much more likely to be diagnosed as carrying a fetus with spina bifida compared to non-Hispanic white women or non-Hispanic Black or African American. So the prevalence is different in these populations, yet they're not equally represented or represented with the same proportion in women who are undergoing open maternal fetal surgery or any type of surgery for spina bifida. Next slide. Why is this? We don't know. There aren't a lot of great studies about this. I think anecdotally, probably some of this has to do with access, whether women are getting, prenatal care in a timely fashion, Are they getting referred to a fetal center? Do they live in a reasonable distance to travel to a fetal center? Are they aware that this exists? So women who don't have internet, who aren't readily, accessing internet, who may have language barriers, may not be seeking out alternate treatments or, looking for alternate therapies. And then when you have any type of fetal procedure, we put the moms on bed rest. We sort of limit what they can do. Many times they need to relocate into the area where they're having the fetal therapy so they can be close to the fetal center. So that means, there's a lot of financial constraints, not only for the patient, but her caregivers, her partner. There's a lot of lost work. And then what do you do with your other children at home? Do you leave your children at home with a family member? Do you all relocate for the time being? And then there's also some cultural differences in how they view these procedures. Even though some of these procedures have been around for 20 and 30 years, they're still perceived as research, and there's a lot of medical hesitancy in some of the groups. Next slide. There's a lot coming in the future, trending towards minimally invasive procedures to minimize maternal risk. Gene therapy and stem cell transplant are very minimally invasive and may have a humongous impact on what we're seeing. And then the artificial placenta to support not only fetuses and newborns who may have complications with fetal surgery, but also prematurity. I think some of those things are a little bit off in the future, but really where, we're going to get a bang for our buck and where we need to do a lot of work is with outcomes monitoring and transparency and reporting. There's not a formal program. Fetal therapy centers do not have to report their outcomes. It's really, it's a collaborative effort. It's a little bit of an honor system, and that's kind of where we are with it. Next slide. In the setting of all that's developed, some of the key points along this journey were in 1982 when a group, basically a consensus group, got together and they wrote a letter about the tenets of fetal therapy, and it was published in the New England Journal of Medicine, led by Dr. Mike Harrison. And this really sort of spelled out what we should be doing from like a care standpoint, an ethical standpoint, the support that should be there for patients. And, from 1982 really until 2017, when we reinvigorated that statement and reinvested in it, things have kind of stayed stagnant. But along the journey, in 2004 is when we really had a lot of traction. So up until that point in time, centers were sort of doing their own thing, and it was haphazard, and it wasn't really collaborative. And so in January at the Society for Maternal Fetal Medicine, there was a fetal therapy working group that came together. And that group at the same time met with the NICHD in August. And really what happened at the end of that was that there needed to be a group to could follow and track these outcomes. And that's how the North American Fetal Therapy Network was formed. Next slide. And so NAFNet was established in 2005 and initially only included 12 centers. Membership is now 40 centers pretty much throughout North America. Member centers pay annual dues, and we do have a little bit of funding from the NICHD, but the mission of NAFNet is to provide a clinical research network that's collaborative in nature and develop therapeutic options to improve outcomes. It also is an educational and training resource so that we can continue to have folks who are in this field. But the scaffolding is there, the background is there for us to do a better job of tracking outcomes and monitoring who has access. We just haven't matured to the point where it's facile yet. Next slide. So I thank you. This is our favorite day of the whole year here at CHOP. This is when our fetal families come back for a reunion. And unfortunately, because of COVID, we haven't done it in a while. But it's truly amazing to see these families after they've, sort of seen the worst day possible and what life can look like for them and the smiles on their faces when their kids are 2 and 5 and 10 years old. Thank you.
Thank you so much, Dr. Moldenhauer. That was fantastic. All right, Janelle, I see that you have a question.
I apologize. I do not have a question. I'll lower my hand. Thank you.
Oh, okay. Steve. Oh, you're on mute, Steve.
Yeah, Julie, thank you for the great presentation. I have a question too. During the fetal procedures and the myelomeningocele open procedures, what kind of anesthesia are used for mother and baby?
So yeah, so the fetoscopic, the more minimally invasive procedures, it depends. We here at CHOP, we use like IV sedation with local on mom's skin, and then sometimes depending on the fetal movement, we need to give general, but the baby also gets an intramuscular shot that includes like a vecuronium and a fentanyl type of mixture. Because if we don't paralyze the baby, the balloon will come right back out. And so then with the open fetal cases, mom goes under general. And so the baby gets some of that through the placenta, but then once the uterus is open, we also give the baby an IM shot in the same way.
Okay, thank you.
Yep.
Magda.
Well, that was a brilliant presentation, and I
Thank you.
feel honored to hear how this field has progressed. So thank you. I agree with Dr. Conry's remarks about this is a superb and balanced discussion. So I want to leave with gratitude. This is relatively a new era for me. I've not been a hospitalist or a clinician for a number of years, although I'm an old Philly girl. So thank you so much for representing
there you go.
City well. Here's the question. If I heard you right up front, because I do public health, right, and I'm in the population-based side and the prevention side. I really appreciate how you spoke to the nuance, the balance of risk. That is a series of trade-offs, and I think your quote up front was, "This is where mom is an innocent bystander who agrees to take on risk." And I'm really struck with that language about her being a willing, innocent bystander. If I did a little bit of research before talking, I looked at the review article around maternal risks of fetal therapy that I think is Al Rafai, published in 2017, looking at the complication rate for moms in minimally invasive is about 5%.
Yep.
And I was wondering, after all that you have convinced us, that was your point, convince us about this, can you put on a hat that says, what about the other side of the equation? We are the Secretary's Advisory Committee on Infant and Maternal Mortality. Yep. And so can you speak to the maternal risks in a little bit more depth? What is the risk for severe maternal morbidity in this particular pregnancy? At what point of gestation? And then what about her subsequent reproductive life course, either with or without fetal therapy? So not taking away the brilliance of your presentation and asking if you can zoom out and talk about her and how is this innocent bystander dynamic established? Help me understand that.
Yeah, I mean, honestly, when I'm counseling a mom, I almost see my job is that I'm trying to talk her out of it. And if after I've told her every negative possibility and she's still, engaged and wants to do it, then that's truly informed consent. So I think, like for us, when we do open fetal surgeries, it's a 2-day process for patients to go through all the diagnostic workup and get counseling and then meet with like neonatology, anesthesia. We don't even want to hear what her decision is until she's met with everybody under the sun and understands every single risk. And so the risks are a little bit different depending on if it's like minimally invasive versus open maternal fetal surgery. So, major complications with minimally invasive are rare. It's a couple of %, but overall there's more. We've transfused moms who have had minimally invasive surgery. It's a rare thing to have happen, but it's there. The likelihood of having like a uterine rupture in the index pregnancy or subsequent pregnancy with a minimally invasive procedure is not 0, but it's pretty low. And as far as this is how it like impacts her reproductive life plan, for a mom who's, this is her first pregnancy and she thinks that she's, going to plan to have 5 or 6 kids, having open maternal fetal surgery in pregnancy number 1 is probably not a good idea. You know, what that means for her is that we're making that incision in the thicker active portion of her uterus. So the risk for uterine rupture and dehiscence is there not only in the, you know, index pregnancy, but for every future pregnancy. Probably the best data that we have for uterine rupture and subsequent pregnancies came out of the myelomeningocele registry, and it was 10%. And of those, we had 2 babies that were lost. One mom ended up having, you know, a laparotomy, massive blood transfusion, bowel resection. So it's not insignificant. You know, I agree with you. Like, you know, these are not things that we can take lightly. You know, there are sometimes moms who have high risk factors, but, you know, they're not a candidate to have open fetal surgery. So, you know, like moms who have a cardiac arrhythmia or, you know, hypertension that's poorly controlled, diabetes that's poorly controlled, they may not actually even be candidates for fetal surgery because the maternal risk is simply too high.
And a quick follow-up, who pays? Who pays for this? I really appreciate you talking about the disparities and the financial hardship, but does private insurance pay for this? Does Medicaid pay for this procedure?
Yes, both.
Thank you.
Yeah, it's the support. You know, like at CHOP, I showed our data, and we have a very, you know, well-developed network here that's basically from our former patients who've given back in, you know, philanthropic roles. And we have a pretty robust fund for patient travel and housing so that they're not limited by resources to get to us and have, you know, therapies done if they need it. And, you know, you saw our data are still very much skewed to educated white people. So, and that's having a very robust, you know, support system for patients that don't have resources.
Thank you again.
You're welcome.
Thank you so much. Colleen, this is the last question.
Yes, thank you so much. I just wanted to ask Dr. Moldenhauer a question. I'm a neonatologist, so I see things from that side of things. And I really am amazed by everything you do, and I appreciate it so much. And I can tell you from meeting with many, many families who have had fetal surgery at Northwestern, like they are so like amazingly grateful for this. And I think it's such a really unique journey that they have. And we had a family that was lined up to kind of give a personal experience narrative about their story. But we kind of didn't have time for it, I guess, but maybe in the future we could, because it's really great to hear from the families who have gone through this with you, because that's where you really kind of understand. And I think speaking to, you know, yes, the families have to understand the risk, but what I find is if they're not, you know, if they're not actively seeking it out on the internet, or maybe they heard of it from a friend, the gatekeepers are truly the obstetricians and the midwives that see them in the beginning. And if those people aren't at least offering them, you know, keeping the door open that they could learn about it or be exposed to it, have an introduction to it, you know, they have a right to know that this is an option. And I think that any obstetrician or woman's provider that doesn't tell them about this like this therapy is really doing them a disservice and not like serving their patients in a complete way. So I just wanted to thank you for this. I think, you know, you have a great attitude and you're very open and honest. And I think that if we didn't have a great center in Chicago, I would send patients to you on the East Coast. So it's good to know another.
Thank you. You have great people in Chicago.
Yeah, they are really good. Yeah. Thank you.
Thank
you. All right. Thank you to both of our speakers. Thank you so much, Dr. Tepper and Dr. Moldenhauer. It was
Thank
just
you so much.
Really appreciate your time. And I think, as you can see, everybody can see this is a huge topic, lots of areas so that we can improve access for all women, no matter what their race. And so hopefully we can continue this discussion at future meetings. So thank you so much. And so Ed, I'll turn it back over to you.
Thanks so much. What a great session. It's always a good day when I learn something, and I learned something in this session. In fact, I learned a whole bunch of things in this session. So thank you very much.
Very good. Good one.
We're going to take let's see, a 10-minute break instead of a 15-minute break, and so we'll come back at 3:50. So I guess it's a 12-minute break. So come back at 3:50 for the next presentation. Well, welcome back to the second part of our first day of our ACIMM meeting. And we're going to be talking about state and community projects on maternal health. In this area, we've sort of put the cart before the horse. Based on input from our community members, we actually included recommendations related to the quality care collaboratives in some of our recommendations before we even had a formal session to talk about them. But I trust in all of our members to bring us the good information. So we're going to be doing the horse part now. We did the cart, and now we're going to do the horse. So Steve, I'm going to turn it over to you to take us through this session.
Great, thank you, Ed. So what we're going to be planning for, we have 3 presenters here that we're hoping for 10-minute presentations followed by questions and comments at the end. Each of our presenters really does deserve more than 10 minutes, but I'm sure that their presentations will really whet our appetite for further investigation of their really good work. So our first presenter is Tammy Snyder Murphy. She has been the First Lady of New Jersey since 2018. In 2019, she launched Nurture New Jersey, a statewide awareness campaign that was committed to reducing maternal and infant mortality and ensuring equitable care among women and children of all races and ethnicities. It focused on improving collaboration and then programming between all the departments, agencies, and stakeholders with a goal of making New Jersey the safest and most equitable place to give birth. In January of this year, she unveiled the Nurture New Jersey Maternal and Infant Health Strategic Plan. That was a plan to reduce maternal mortality by 50% over 5 years and eliminate racial disparities. And it's a culmination of a lot of work. We welcome Ms. Murphy to present to us, and are thankful for being able to take the time.
Well, good afternoon, everyone. Dr. Calvin, I am grateful for that introduction and for your work as part of the Advisory Committee on Infant and Maternal Mortality. I also want to share that we are keeping our eyes on Minnesota. Earlier this year, the University of Minnesota's School of Public Health submitted a response to our request for information to aid in planning our Maternal and Infant Health Innovation Center. And I cannot overstate how thrilled I was that the work we are doing in New Jersey is making rumbles all the way to Minnesota. It is an honor to be with all of you, and I want to thank Secretary Becerra for his recognition of the United States National Maternal Health Crisis and his support of our work here in New Jersey. I also want to thank Dr. Ellinger, chair of this advisory committee, for his leadership and dedication to our nation's mothers and babies. In his inaugural address, President Biden spoke of, quote, a cry for racial justice some 400 years in the making, a cry that can't be any more desperate or any more clear. In New Jersey, I have spent 4 years listening to this cry grow louder from Black mothers who have lost their babies or very nearly their own lives, fathers who have lost their life partners, and countless women of color who have told tragically similar stories. Stories of not being listened to or receiving the care that they needed and deserved at a time when they could not have been more vulnerable. And as we have worked to raise awareness of this crisis, as well as solve it, I have seen New Jerseyans from every corner of our state respond, some with shock and outrage, others with sadness, but all with a determination to raise up these collective voices and demand an answer to their plea for racial justice through reproductive justice. Through Nurture NJ, we seek to answer that call. Over the past 4 years, we have taken a comprehensive and meticulous approach to understanding the scope of New Jersey's maternal health crisis, made significant and often groundbreaking policy changes. We've enlisted national experts to help us design our Nurture NJ maternal and infant health strategic plan, and we've begun to implement many of its recommendations. Some of our most significant accomplishments since the start of the Murphy administration include becoming among the first states in the nation to establish a statewide universal newborn home visitation program, expanding Medicaid coverage to 365 days postpartum, providing Medicaid reimbursement for doula care, and the list just goes on. I am incredibly proud of the steps we have taken thus far, but as we work to fully transform New Jersey's maternal health landscape, we understand that sweeping change requires persistence and unfailing dedication. At the same time, we know that the urgency of this crisis remains and that its root cause is institutional racism, plain and simple. Black women in New Jersey are over 7 times more likely than white women to die due to maternity-related complications, and Black babies are over 3 times more likely than white babies to die before their first birthday. As a mother of 4 incredible children, this terrible knowledge weighs heavily on my heart, especially because I know, but for the color of my skin, that could have been me or one of my children. And that kind of personal commitment and motivation is reflected in every Nurture NJ partner. We're not seeking to simply improve our maternal health statistics or data. We're working to make sure that every New Jersey mom and baby gets off to a healthy start and is put on a trajectory toward a full and healthy life. In January of 2021, nearly 1 year ago, we released the Nurture NJ Maternal and Infant Health Strategic Plan, which is the culmination of over a year of innumerable conversations with hundreds of relevant and invested entities, ranging from departments and agencies, health systems, physicians, doulas, community organizations, and most importantly, mothers and their families. Designed to make transformational change in a system that has historically failed our mothers and babies of color. This plan is our blueprint to make sure New Jersey is the safest and most equitable state in the nation to deliver and raise a baby. At its most fundamental level, the plan meets the specific needs of women in their local communities, where they live, work, worship, play, and love. The recommendations range from increasing prenatal care and support for women of color to creating a groundbreaking maternal health research and innovation center so that our work can continue to grow, evolve, and inform itself. Most importantly, it makes broad reforms aimed at dismantling the structures that for generations have prevented women of color from living in environments that provide the resources needed to simply be healthy. The goal to reduce our maternal mortality rate by 50% over 5 years and eliminate the racial disparities in birth outcomes will require all sectors, health, education, business, government, academia, and more to play an integral role. And ultimately, the success of our plan relies on the active partnership and collaboration of all of us. Since the start of our administration, we have held quarterly Nurture NJ interdepartmental maternal and infant health work group meetings with over 18 different departments. We've held 6 family festivals to bring together state, county, and local resources to over 5,500 families in our cities with the highest rates of Black maternal and infant mortality, which was accomplished in large part due to our partnerships on the ground with community organizations, faith leaders, school districts, elected officials, hospital systems, and more. And most recently, we held our 4th annual Black Maternal and Infant Health Leadership Summit, where over 350 participants, including doulas, nonprofits, activists, state departments, and agencies, and most importantly, moms, came together to discuss and identify solutions to our maternal and infant health crisis. I am proud that because of our work to dismantle silos, build trust among our over 800 Nurture NJ partners, and amplify the voices of the mothers affected by this crisis, we have been able to hit the ground running. We are 3rd in the nation to reimburse doula care through Medicaid. We have the most robust universal nurse home visitation program in the nation for new moms. And we are the 2nd state to expand Medicaid coverage to a full 365 days postpartum. My husband, Governor Murphy, has signed over 37 maternal health related pieces of legislation, from ensuring hospitals ask any patients presenting in the emergency room simply if they have delivered a baby in the last year, to no longer reimbursing for early elective C-sections through Medicaid. We have made small and big changes with a major impact. In less than a year from its release, we have already completed or made headway on over half of the more than 70 recommendations outlined in our strategic plan, ranging from establishing a maternal and infant health research and innovation center to expanding coverage for reproductive health for our undocumented mothers, and several of the achievements I already listed. With our collective and persistent commitment, we will root out the institutional racism that has affected every corner of our society, all the way to our mothers and babies. It's clear that our country has reached a crossroads, but I do not say that with fear. I say it with the utmost sense of optimism and hope for what we can and will achieve together. As we come together to face our nation's racist past and present, where better to start than where life starts, with our mothers and babies. When we do this work, we do it for the tens of thousands, even millions of mothers and children we will never know, but we also do it for our own mothers, our own children, our grandmothers, our aunts, nieces, and our friends. We do it for those who are no longer with us and for those who have yet to be born. We do it because we're ready to turn the page to a future where every family gets off to a healthy and happy start. And New Jersey has a plan to get us there, a blueprint that we hope not only for the Garden State, but for tackling systemic racism across the country and leading the nation in maternal health. So here I would like to express my gratitude to all those who contributed to the development of our plan. And I want to give a very special thank you to the women of color who shared their deeply personal and painful stories with us. Your voices are the DNA of this movement. In New Jersey, we have a lot more work to do, but because of the leadership of the Biden administration and all of our federal and state partners, like New Jersey's own Senator Cory Booker and Congresswoman Bonnie Watson-Coleman and Congresswoman Lauren Underwood, when I say that Black mothers' lives matter, I know that along with those words comes action. Not the kind of action that makes a small change here and there, but the kind that's going to transform New Jersey into the safest and most equitable place in the nation to deliver and raise a baby, and our nation into a haven for mothers, babies, and families. Thank you for your attention. Thank you for your concern. Thank you for looking to New Jersey for guidance and joining us on this journey. I truly feel the momentum growing behind us, and I know that together we will solve this crisis and ensure a healthy start for every mother and every baby. Thank you.
Yeah, thank you very much, Ms. Murphy. That New Jersey is fortunate to have someone who is so passionate and driven about improving maternal and infant care. We're really grateful. So we'll look forward to some questions at the end of the other two presentations. Our next presenter is Dr. Elliot Main. He is the medical director of the California Maternal Quality Care Collaborative, and he's led multiple state and national quality improvement projects. I've been aware of him for a long time. It's a real honor to have connected with him last week before this presentation and to hear this presentation. He's been chair of the California Pregnancy Associated Mortality Review Committee since it was started in 2006. He's has been chair of a very large hospital OBGYN department, and he's currently clinical professor of OBGYN at Stanford. He's chaired also many national committees on maternal quality measurement, including those sponsored by ACOG and the Society for Maternal Fetal Medicine, I think, for sure AMA, the Joint Commission, Leapfrog, Centers for Medicare and Medicaid Services. He's just, he has been very active and it's not an overstatement to say that hundreds of thousands, indeed millions of mothers and babies have benefited from his work. So we are thankful that he could join us today. Great.
You're muted, Elliot.
Oh, yeah. There you go.
Thank you very much, Steve. And I want to give a special shout out to First Lady Murphy for the tremendous work she's doing in New Jersey. And it's really bringing the power of the governor's office and the power of the collective work of everyone in New Jersey to bear on this. And we're learning from her as we work in our progress in our state. So I'm going to show you the power of a public-private collaborative to work on maternal. On the maternal side, we have a parallel group in California called CPQCC that's working on neonatal health. California is particularly important because we're very large, larger than most European countries, with almost 500,000 births, a little fewer in the last years of the pandemic, and a very diverse population. Actually, 47% of our births are Latina, 6% or so are Black, 17% Asian American, and only about 30-odd% are white in California. Our collaborative was formed in 2006, so we have 15 years of track record here, which is important as we look at other states that are starting out. And you can't expect change to happen in 1 or 2 years. It's taken us, with the development of relationships and track record, a long time to get where we are today. But we were formed by the Department of Public Health, and Dr. Connie Mission is going to follow me talking about their side of the story, and they've really been the leaders in this. Got us going. First, with a look at maternal mortality. We did not have a maternal mortality committee in California until it was started shortly after 2006. Our mission was to turn the results of the mortality reviews into action. So I'm going to look at 2 of the key slides of our outcomes in California. One is maternal mortality. Again, we started around 2007 looking at maternal deaths. And then I'm going to go through the steps that we took to start making change at scale. And again, California is 1 out of every 8 births in the United States, bigger than most European countries. So this is really about change at scale for maternal mortality. And then more recently, low-risk first birth C-sections. Again, our story was we were the same as the US in rates, not very good. 26% for the low-risk first birth C-section or NTSV. And then with a combined public-private operation initiative, we were able to significantly lower that. The green line on the right-hand curve is baby outcomes, severe unexpected newborn complications. And you can see that we did this because we wanted to show that they were not harmed by having a lower C-section rate. And in fact, they actually improved with a lower C-section rate. There are a lot of important steps in this, and this is the mantra that we have taken for most of our journeys. First, all being driven by statewide public health data like mortality review committees, developing a toolkit, engage every partner organization that we could around the state, hospital change collaboratives with rapid cycle data, and this is going to be a particularly important part for us to lead to change at scale. For example, on the right-hand side here, our statewide initiative for reducing primary C-section or supporting vaginal birth, we combined hospital QI collaboratives that were data-driven, had a lot of professional organization leadership, driven by collection of data in a toolkit and direct participation of women. At the same time, we engaged health plans, our Medicaid agency, purchasers, our public health department. Actually, the Secretary of Health and Human Services for California gave awards to hospitals who achieved targets. And we had public reporting, a lot of transparency, which was the key element. These all combined and in a synergistic way to actually create that change at scale. So quality improvement toolkits, These are 50 to 100-page documents giving all the nuts and bolts of how to create change locally at your facility for various topics. We just finished an update to the preeclampsia toolkit that was paired with the national safety bundle, and had 2,000 registrants for our webinar releasing that. These are paired with collaboratives, and these are IHI type of collaboratives where hospitals work with each others and with community groups to address the specific issue. What's important here is that one collaborative does not change the world. You have to do them repetitively so that you develop a change in culture of the unit, so that you really are changing the outlook, changing the approach. We have done a whole series of these, starting small, 20 hospitals, and then up to 90 hospitals, up to 130 hospitals at a time. We have 230 odd hospitals in California, making the change process a challenge. Underpinning this is the maternal data center. And this we're going to spend a couple slides on that because this is super important. We were able to, with our Department of Public Health, turn our birth certificates into quality improvement tools. So we get feeds every month from our Department of Health of every birth certificate in our state, 30 days old. 30 days old. Link that to hospital discharge diagnosis files from every hospital in the state. Again, those are now about 45 days old. And we can put those together, mother and baby and birth certificate, and then turn that around to use for hospital QI and for supervision of state practices in near real time. So hospitals, we have reports that enable our hospitals to calculate and then report to outside agencies and to benchmark against each other a whole series of quality measures and stratify them by race and ethnicity. And we'll talk about that in a moment, because we are able to use the race and ethnicity on the birth certificate, which is probably the best or the gold standard. We create enough value for the hospitals in this process that now they're supporting the data center with a modest fee per year from all 215 or so hospitals. Because, and that's really a key point in all this, is that you want to create value for every stakeholder along the way to get them to buy in. This is doable potentially at every state. It is about breaking silos between birth certificate, i.e. health department, and the agency that collects and stores the hospital discharge diagnosis files. But in many states, these are burdened by rules. So that requires leadership. We don't want to invent the rule with a whole new data system. It's there in every state. So our mission, I think, here ought to be to really impress upon states that they need to change their regulations and laws to accomplish this. So I mentioned stakeholders and partners. I think our strength as a public-private organization has been to engage actively everyone we could think of who touches maternity care. And that involves a series of state agencies. Dr. Mitchell will talk more about membership association. Our hospital association's been a big player. All of our health systems, we have a lot of health systems in California. Kaiser's, Sutter, Sharp, Dignity, Providence, public hospitals, as well as a series of professional groups and public, consumer, and community organizations. But importantly, also the health plans. The people who pay the bills are really important in this because they can provide incentives to participate and incentives to achieve targets. But national partners also play a big role. We've been able to work extensively with the Joint Commission in my role both in California and with the HRSA supported AIMM project that's based at ACOG and involves many national organizations to adopt the hemorrhage and hypertension bundles and to set as a promote a set of perinatal quality measures. State perinatal quality collaboratives like CMQCC have been supported by HRSA. And it's a shout out to Drs. Warren and Wilson here in the audience today. They have been able to help create national safety bundles, which really provide guidance to what we should be doing locally. The CDC in turn has been supporting PQCs, and again, a shout out to Dr. Barfield here for supporting supporting us initially in California and now turning to newer state perinatal quality collaboratives. But it takes time to nurture. CMS more recently has been involved with the inpatient quality report as a new measure for adoption of state perinatal safety bundles and participation in state PQCs. And indeed, we have participated actively with our state's Medicaid agency in supporting OB quality through 1115 waivers, which is something open to every state. I think is an opportunity to be able to rechannel significant support in that direction. I'd like to say, that we've made a lot of progress, but in other areas we haven't made as much progress as we should. And this is areas that First Lady Murphy has really highlighted today. In our hemorrhage collaboratives, we were able to narrow significantly the morbidity for Black women compared to white and Latina women by about 50%, but it's not the same. That has led us to look at antecedents and prenatal care and other areas such as pre-existing anemia that need to be addressed. Our cesarean collaborative reduced the rates for all racial and ethnic groups in California, but did not close the gap. We still have a 30% reduction as opposed to a 6 percentage point difference between Black and white women is now 4 percentage points. So progress, but not there. There's two ways of looking at maternal mortality. I showed you the first graph. It was the WHO definition, which is up to 42 days. The pregnancy-related mortality rate goes out to a year. And after a 30% reduction in pregnancy-related mortality in the first few years of our project, it's been flat. And so now there's still a significant disparity between Black and white women, and this is an area that we're focusing on now with a lot more community engagement than before. And it represents a shift of deaths to postpartum period away from L&D. And our feeling now is, and we're late to the game on this, I will admit, is that we really can't do quality improvement without really addressing equity. That's some of the learnings we've had over the last 3 or 4 years. And so we're trying to weave intimately equity into every quality improvement project. But in our healthcare system, such that it is, there's a lot of connections that are lacking. Communities and health systems do not speak often with each other. Medical model and the public health model can do much better to work together. Physicians do not understand the resources available to them in the public health world, and I would say vice versa. And in and outpatient worlds are pretty distinct in quality improvement. So these are opportunities. Going forward to our work with race and ethnicity, I'd like to make one illustration here in the last couple of slides. This is a hospital's NTSV C-section rate. They thought they were doing great, 22%. National target was 23.6 for healthy person 2030. They had no idea of how they were doing by race and ethnicity until we were able to show them in our data center, stratified by every race on the birth certificate, that their Black mothers were doing 6% higher. Huge disparity, even though overall they were doing great. With this knowledge in hand, they were able to go back and focus on equity and quality improvement together. And 2 years later, 2.5 years later, they had a significantly lower rate for their Black mothers, 22 versus 28, 22.9 versus 28, but there's still a difference, 18 versus 22 overall versus, so there, but this is a start. First is that they have to recognize what is happening locally in their own facility. So our feeling about keys for improving care at scale was to use the public health surveillance data to create the burning platform for change and to drive actions. You got to mobilize everyone you can think of, including communities. You create a system of rapid cycle maternal infant data to support and sustain the QI projects, and then also have a data-driven large-scale quality improvement projects to change the culture, because that's really about culture at the end of the day. And you want to pull all the levers at once, not just do a collaborative, not just show some data, but to engage everybody at the same time with the transparency, with all the levers that I showed in one of the earlier slides. And you have to do equity and clinical QI together. Thank you very much.
Thank you so much, Dr. Main. This has been great. And I would just, as you were describing all of this, I think you're the composer and director of a very large quality improvement orchestra. And you know that all the sections and all the players and sometimes soloists, they're all playing, but it's amazing what is being accomplished, and it's a model, I think, for the rest of the country. Our next speaker is Dr. Connie Mitchell. She's an emergency medicine physician, and her career has spanned the spectrum from the highest acuity interventions in the emergency department to health policy for primary prevention. As I was reading her bio, it brought me back to something that I heard 30 years ago from a head of a department that said that, we could always be down at the bottom of the cliff, picking up the people that have fallen off, putting them in ambulances. He said, we need to put fences at the top and stop people from falling off. And so I think that's what Dr. Mitchell has been doing. She has a particular focus now on maternal, child, and adolescent health. She helped start the California Pregnancy Associated Mortality Review and is a colleague of Dr. Elliott's. She was the author of the state's first report on maternal mortality, and she is on the front line of quality assessment and improvement, and we're grateful for her participation.
Thank you very much. It took a second there for it to clear. I'm very happy to be here and very happy to follow the two speakers that you've just heard. I'm really appreciative of the First Lady's remarks, because I have found through experience that it requires just such a strong vision and goal setting in terms of all leadership and all forces. And then you have to align the resources with your values. So if you talk about starting with the people who give life as a good starting place for our work around equity and anti-racism, then giving aligning your resources with that is really important. And then I think I really appreciated how she talked about building a big tent, but making it easy for others to join that big tent. That's sometimes we have a big tent and it's people who have the means and the mechanism and the recognition to join, but you have to make it easy for people who have the lived experience, who come from the community, who understand the barriers the most to participate. So I really appreciated her comments. And Elliot described something that we're very, very proud of in terms of our public health department. And that is that you really can provide important seed funding to an organization and then foster and support them as they grow and learn and become more independent, yet still part of your team. We were really happy that not only did we use our Title V funding in California to help to create the California Maternal Quality Care Collaborative. Stanford University is the home for that collaborative, and we continue to contract with that collaborative. but worked with them to then take it to the next step. The next step being, okay, if we can do more real-time quality improvement, what would it take? What data would you need to get to that point? And we tried to facilitate that for them so that they could do that. And then we made it really clear that while we couldn't fund that, we would support it in terms of supporting their ongoing executive committee. They continue to, under contract, lead our current maternal mortality review committee. So we have a very close partnership, but even more importantly, that seed money was critical for all of the success that you've seen Elliot define, that now they are able to add additional payer mechanisms and incentivize hospitals to participate. So anyway, if you'll go to the first slide, I was asked by this committee to talk about our approach and how it started up. And in a way, maybe I should have gone first, but we'll talk about how this all started up. And we'll also, I was asked to talk about some of our challenges that we still have that remain, and maybe some ideas for how federal agencies can work with us to support our improvement. Next slide, please. So we started like any good public health endeavor would be, is that we started with hypothesis generation. And we had a lot of hypotheses as to why in 2006 and 7 and 8 we saw our rising rates of maternal mortality. And one of those hypotheses was, had something changed in terms of obstetrical care? Was something different going on in either the care provided or the status of the patients, or you know, what was happening either prenatally or in the hospital phase? So it made sense for us to begin with the medical record and looking at the medical record because it's available data that's already there, and we have the authority through the public health to be able to get into that data, ask for that data. But what was critical in California, and we shared this belief, was that if we did it as an oversight agency, we would not engender the goodwill of the hospitals to let us look at some of their most private moments where we did discover that we didn't always reach the standard of care that we hoped to reach. So we made sure from the very beginning that this was about working together and using the medical records, conducting a public health investigation, using the expertise of our committee to try to not only ascertain, try not just gather the data, but also to ascertain were there moments there as we read about this case where it might have gone differently if something else had happened instead. And I remember being in those first reviews where the room would go completely quiet because you realize that it might have gone differently. This life might have been saved if something at that point you went right instead of left, and the room is silent and everybody felt this pain, and we had to have the trust of one another that we had to move beyond the pain to convert it into meaningful data, and that data could then inform some guidance for hospitals. And then we needed a trusted partner to bridge and provide that guidance and work with hospitals who wanted to do better. And that was kind of our mantra from the very beginning, is that we all want to be excellent. We all want to serve. We all want to prevent these deaths. And we want to do this together. And so CMQCC provided that bridge to the hospitals and the healthcare community and did some real-time quality improvement. They helped us to develop these toolkits, these guidance documents based around quality improvement. They worked with hospitals who signed on to these learning collaboratives, and they gave them the information that they needed to see if they were moving in the right direction or not. So it was truly not only a partnership in moving forward, but it gave us real-time accountability very visible accountability so that the hospitals could know that they were making progress. Next slide, please. So you saw this slide with Elliot. This is a slide that I've seen a lot of people point to and they want me to explain it. And what I have to really tell you is that I have to really address this with all humility, and that while we were able to make some changes, I don't know exactly what they were. I can tell you the things that we did, but it may not have been exactly those things, because we had so many people in California committed to reducing maternal deaths that it may have been little things that accumulated. I can't tell you that is specifically what we did that contributed to this, but we did see a gradual decline. And this is, again, maternal mortality rate being up to 42 days using death certificate data alone and the ICD-10 codes for obstetrical deaths. It's readily available, it's feasible in all jurisdictions, it allows for cross-state comparisons. Next slide, please. But it's not telling the whole story. And we need to be very honest about that, because I think we need to do a much better job at telling the whole story. So you can see in this slide that, again, that maternal mortality rate, the gray dotted line at the bottom, that's that same data line. And you can see the top line, if we look at maternal mortality up to 365 days, and this is something that we're very committed to doing, and also I heard that New Jersey is and other states are, you can see that our rates, our pregnancy-related mortality ratio rates are higher, much higher. 14 in 2016, 14.1 compared if you go to 365 days, and 5.9 if you go to just 42 days. The middle line, the dotted line, is the data that we have. If you look at our data on pregnancy-related mortality ratios, which comes from multiple data resources, vital stats, medical records, ambulatory care records, coroner and autopsy reports. So you have multiple records because you're trying to identify all of the deaths. And if you look at that only to 42 days, what we think is a more reliable data source, multiple data sources, gives us a pregnancy-related mortality ratio, because it's not based on just on vital stats, of 11.9 in 2016, compared to 5.9 from death certificates alone. And again, the 14.1 is if we go out to 365 days. So this right away, I want to tell you is an important thing, is that the snapshot that we use of maternal mortality ratios is not sufficient to really describe what we think is happening. And we're so appreciative of the policy efforts to extend prenatal care and postnatal care to extend postnatal care to 1 year. That's one example of things that we can do to perhaps address this. Next slide, please. So again, with all humility, we have made some improvements. We know that, but we are facing a persistent and very discouraging disparity. And I just listened to the First Lady and I felt uplifted that I think that if we have an all hands on deck approach to this, and that we really do the hard work that we need to do, that is around the environment and addressing historical and institutional racism, that we will come up with strategies and we will make some progress. But when you look at this is our data, it's a 3-year moving average, you can see at the bottom, and you can see the division by races. And I think that Elliot showed us a similar slide to this. It shows, it looks like there's some improvement in, you can see the narrowing of the disparity ratio, but when you actually calculate the ratio, which is the dotted line in the middle, we have not improved. We are at the same disparity ratio that we were in 2003 to 2005 of 3.9 is that ratio. Next slide, please. And this is again where if you look at the pregnancy-related mortality ratios and you out to 1 year, and it's the same slide that I just showed you. And what you see here is that at 1 year, the deaths among Black women, the ratios increased 42.5 and 14 to 2016. And you can see that the ratio, because the deaths in white women went down a little bit, these ratios really jump up. So instead of being a ratio of 3 to 4 times, a death rate of 3 to 4 times that you get at 42 days, it's a ratio of 5 to 6 times that you get when you look at 1 year. Now that's important information, because then you want to say, well, what's happening with that group? We know that, and I do want to point out that we have to take this with some caution, because these differences are not statistically significant, but the trend is concerning. So I want to be really clear on that. The ranges that we see could be expected by chance alone. So this disparity ratio should be interpreted with caution, but I want to present it to you. We know that our pregnancy mortality ratio is higher in older age groups and those with higher BMIs, greater than 40, those with less education, those with on public pay versus a private pay system. But very importantly, it's higher in those living in the most disadvantaged communities in California. Next slide. So I was asked, what does California see as major challenges to improving maternal health? Certainly addressing the disparities in perinatal outcomes by addressing systemic racism and social determinants of health. Women remain a social, economically vulnerable population, and the intersectional effect that comes with joblessness and mental health, loss of housing, food insecurity, structural racism, and low rates and access to health insurance all contribute to poorer outcomes in pregnancy. We must use the life course approach to risk reduction and resiliency promotion. I think one of the things that we did when we developed the toolkits and we engaged hospitals in quality improvement efforts, but I think we did improve rescue care. But I really think that we can do so much more upstream and thinking about reproductive health as a continuum from childhood to parenthood, and that experiences prior to pregnancy matters, so that the health of girls and women prior to pregnancy is optimized before pregnancy. We need to increase support for other health risk conditions such as behavioral health and chronic diseases that I think are all contributing to rising rates of maternal morbidity. Something that we don't think about a lot is reproductive health literacy for all, including understanding of the pregnancy health burden and high-risk conditions. In our Black Infant Health Program, we surveyed the women participants, and they were not aware prior to enrolling in our Black Infant Health Program of their individual risk just because of their race. So we now have a campaign that's being developed to try to raise that reproductive health literacy and understanding of the pregnancy health burden, particularly in Black pregnant people. And we want to continue to work to improve the quality of reproductive health care, but that's across the continuum. Access to high quality sexual and reproductive health education and services, continuity of care after delivery and connecting mothers to needed health, social, and mental health services, decreasing experiences of racism and disrespect or mistreatment that is regularly reported by people of color in the healthcare system, and a focus on the quality of rescue care, but also the quality of prenatal care and the quality of preventive care in women's health. Next slide, please. So I was asked, what can federal agencies help do to support improvement in maternal health for all pregnant people? Right off the bat is this opportunity with COVID, provide equity-based COVID recovery assistance for families and women. I know we've already done some of this, but we have not yet done enough. Women, and particularly women of color, dropped out of the workforce to serve as family caregivers. Caregivers were asked to sacrifice their time, their salary, their professional advancement, and their own health. We need to have some clear data guidance from the feds for indirect and long-term impacts on families so that we know where to direct our support. We need to have an increased focus on rising rates of maternal morbidity. That's not talked about enough, and the complexity of addressing maternal morbidity, maybe even more so the maternal mortality. There's currently 21 indicators and corresponding ICD codes that can be used to track hospital deliveries, but the administrative data doesn't document disease severity, so it does hinder some of our studies. Another suggestion is to prioritize social support during pregnancy as a routine part of prenatal care, addressing immediately housing and food insecurity, any safety issues, and the need for trauma-informed care. I'd like to suggest too that we have a national learning collaborative. I want to have a meeting right away with the First Lady so that we are all learning from one another and that we can focus specifically on morbidity and mortality and our perinatal outcomes for Black people. Increase our support for parents and a national vision that child rearing is a shared societal responsibility. Certainly universal home visiting, paid parental leave and caregiver leave, and childcare support. We need to incentivize a stronger and more diverse reproductive health workforce. We need to think about Medicaid payments to licensed birth centers or remove the scope of practice barriers by certified midwives, improve opportunities for racial concordance of care, train and incentivize use of doulas, midwives. I know that HHS has proposed to increase scholarships for disadvantaged students to educate midwives. We support that. And student loan repayment for health providers should be included. And finally, address the data quality issues. Move from a maternal mortality rate to a pregnancy-related mortality ratio to capture causes of death up to 1 year. We need to identify best practices for identifying a complete cohort of pregnancy deaths, standardize our processes, require coroner reports and autopsies on all maternal deaths, probably require every maternal death to be reported so that we all commit to this being a high priority need to get this information. I wrote last year, conduct a lean assessment of federal processes to increase flexibility and reduce procedural and reporting burdens. This came from my local health departments and my staff, is that they said wherever we can self-assess and we can remove barriers and make work easier, people have more time to do the work at hand. So that I added that to make sure that we all have a responsibility to remove barriers and make it easier and more flexible so that we can meet the needs of our communities. I want to conclude here that we don't have to, there's some great resources. On this last slide, I have there a list of some great resources, policy resources. So if you can go one more slide, thank you. There are lots of great documents that already tell us what to do. It's now time to start doing it. That's my last advice, is that we know what to do. We certainly have models for the political will to do it. We just need the processes for aligning the resources with the values and with the goals that have been set. And if you want to make it really simple, the next slide, please. I really found that the work for the Center for Reproductive Rights simplified it really easy for us in these categories. We need to improve healthcare access and quality while addressing underlying determinants of health. We need to eliminate discrimination in law and practice. We need to ensure accountability, and we need to include and empower all of the voices that will be essential for us to resolving these big problems. So thank you for including me, and thank you to my co-panelists too. I find you both to be very inspiring.
Yes, thank you very much, Dr. Mitchell and First Lady Murphy and Dr. Elliott. I think we have a little bit of time. Are there any questions? I guess we'll start with Dr. Conry.
Mine is not a question. Mine is just a thank you for 15 years being inspired by the work that they're doing. I'm delighted that they were able to share their knowledge with this group, because I think it's this knowledge and evidence going forward that's so critical for us. So thank you to everybody. And First Lady Murphy, an inspiration for what we need to do with political will.
Great.
Thank you.
Thank you. Ed.
Yeah, mine was a political will question for all of and the political will, not just on the political side and the public policy side, but also in the hospital side. This requires a lot of sharing of information. It requires hospitals to be willing to share some of their data and be visible and be vulnerable. It takes politicians on both sides of the political aisle to respect the fact that we work collaboratively. How did you do it in New Jersey, and how are you doing it in California to get people to play well together and not have an us versus them or a public-private that get government out of activities like this? How do you build that political will? How do you form those partnerships that were so obvious in both of your presentations that are so essential?
Somebody, you want to go first, please?
Sure, absolutely. So it's funny, this is the same question I've been asked literally 3 times this week already, which is extraordinary because we're only on Tuesday. The answer from my side is that we have gone out and spoken to so many stakeholders across the state of New Jersey, in Washington, in New York, truly across the country. And I think that this topic, from my vantage point, at least here in New Jersey, is a unifying topic. Whenever my husband gives State of the State speeches or the budget address, this is the one topic that comes up where both sides of the aisle clap and there's no dissent. So I would say to you that, I think it's a little bit of leaning in and trying to meet with all the stakeholders, whether it's the Black Legislative Caucus on the one hand, and being thoughtful about including potential outliers up front. So in a lot of the conversations we've been having, if we kind of could think down the road where we might have a speed bump, we've actually gone out of our way to include those specific individuals in conversations at the very beginning, so we can make sure that we are all understanding one another. But all the work we've been doing is literally bringing together great people who are working in silos all across our state and beyond. Because there's a lot of fantastic work that's being done, as you all know. But the fact of the matter is that people don't reach out and talk to one another. And I think when you open up those lines of communication, I think that what you'll find is that actually this is a very compelling topic. And I think that most people here in New Jersey agree.
Thank you. Yeah,
I think in a similar way, our first 5-6 years was spent entirely on networking and on communicating and really creating the premise that we're here to help people improve care and reduce mortality and morbidity, which is hard to be against. And so we've tried to accent the positive throughout this process, i.e. giving awards rather than penalties, though, and incentives for achieving goals. And that by and large has been very well received. But we do have economic competitors working together on this. Different healthcare systems are sharing data with us. We don't, only a limited amount of data gets publicly released, but transparency is a very powerful tool. That is not in place in some of the states in our country where they don't believe in transparency, and that's a missed opportunity.
Yeah, thank you. I guess, Magda, you have a question, unless Connie Mitchell, do you have a response as well to that question?
Go ahead, please go ahead.
Okay, Magda.
Thank you, Dr. Mitchell, I appreciate that. I am always in awe of what the California Maternal Quality Care Collaborative has been doing. And I appreciate that it's taken 15 to 18 years, a lifetime, to harvest. So I just want to extend my gratitude to my colleagues who are also my neighbors now. I am struck also by the data that were presented by Dr. Main and later, I think, by you, Dr. Mitchell, around the extraordinarily good outcomes for foreign-born Latina or Latinx women or Latinx women. And I just would, and that has been part of the paradox that Sylvia Gundelman and others have written about for a long time. When you do your work and the disparities are so great, have you also looked at why, in the face of economic challenge, this particular population, apparently by the numbers, does better than their white counterparts who are non-Hispanic? Do we ever look at what are the positives in the data in addition to disparity of our Black and American Indian women who have poor outcomes? So it's a California thing, but I'm wondering if it's beyond the California thing around this paradox.
Connie, do you want to start, and I could answer too?
I'll make a couple of comments around that, and that it's an important question because these communities want us to elevate their strengths and their abilities. We used to have we used to call it a disadvantage index, and they said, no, that means that you are not perceiving the strengths that we have, and so now it's called a healthy places index. We recently did a report on American Indian, Native Alaskan maternal health report. And we did that with the community and said, how would you look at this data and interpret it? What do you see in here? What would be your analysis? And then how does that relate to what you see as opportunities and barriers? And that report then went in a whole different direction. And we're doing the same thing with a report that will be coming soon around Black infant and maternal health. So I would say that you don't identify the strengths and the richness of a group of people unless you ask them and engage them and let their perspective be a part of your analysis and your final conclusions.
It's clear in our analysis that there are a lot more strengths in the Latin community than it is reflected by their income or their personal wealth, which is some of the traditional metrics that are used. But also when we look at comorbidities as a driver of maternal morbidity, and we've developed adjustments for that so you can compare hospitals to hospitals. When you look at race and ethnicity, actually immigrant Latina women have many fewer comorbidities than other racial groups. And so their outcomes are not perhaps quite as good as you would expect when you do the risk adjustment. They're still good comparatively for those traditional income and education level type of measures, but that, as Connie says, does not really reflect the strengths of the community.
Great.
And I just appreciative of that around the weathering effects, if you will, the protective factors, the veneer that wear off with greater and subsequent generations. So over time, your data may tell us something that can talk about those forces.
Okay, well, I think our last question from Janelle, and then I think Ed will wrap things up for the day. Go ahead, Janelle.
Thank you. It's very similar. Thank you for your presentations. And it's very similar to what Magda was bringing up. Just, where are the Native American, where's the data on the American Indian Alaskan Native people? And Connie has provided with the Health Equity Work Group. Thank you, Connie, for the California Department's report on American Indian maternal health. And I was looking through my email really quickly so I could send the link to everyone on chat. So I'll do that as well. And yes, looking at it from a positive perspective versus a negative defect perspective is always key. And so my question then, Dr. Main and Connie, please, Dr. Mitchell, please also just share how are you going about including this data on American Indian Alaskan Native communities, maternal infants. I myself am 3 data points if you include myself and then my 3 children for the state of California. And how are you collecting the data and what kind of partnerships did you have to do to make way? Thank you.
So we have the ability to stratify, as I said earlier, all of our outcomes by race and ethnicity. And we had been hesitant to look at Native Americans as a separate category initially because they were about 1.5% of the population overall. But when you divide it into hospitals, they're very small ends. And we were worried that they may be interpreted poorly because one or two poor outcomes in a small n can give you very high rates. We've since changed that and are now in our current reporting going to be showing Native American as a separate group rather than as a other, with advice about how to interpret small numbers. The other issue that we found similar to the US Census is the race is if you look at women or birthing persons who are multiracial, i.e. Native American plus white or plus Hispanic or plus something else, you would actually more than double the rate of Native Americans in our state. And that's something that's seen nationally as well. And so that's something that we're looking as to whether you want to include Native American plus Native American as part of multiracial is in the same category. And we're going to seek guidance on that. But that almost more than doubles the rate of Native Americans.
Thank you, Dr. Ming. What you're sharing is reflective of just, historical policies that have targeted our people and continue to target as how we are defined. And it is very tricky, I agree. And what we're really trying to capture, right, experiences of those people. And we're using ethnicity in this point as it's a poor measure of experiences. Thank you.
The more I've gotten into reporting by race and ethnicity, the more I realize that race and ethnicity are bogus labels. And it's very, very difficult. But we look forward to your help on that.
Yes, thank you very much. I think I better turn it over to Ed because we're nearing the end, but I really appreciate the three presenters. This has been incredibly helpful.
Yes, I agree. This has been a great session. This whole day has been good, and it highlights for me, when you look at, there are things where we needed a lot more information, congenital anomalies. There's a lot of stuff that we don't know about it, and the interventions have been very medical in their orientation. And then there are on the other side is all of the community activities that are going on, again, where we do know a whole lot of what works. But on the things we don't know on the medical side, we've got the NIH with lots and lots of money who can fund research and move things along. On the other side, where you're dealing with the social issues, there's no agency that says, we're going to give you some money to look at all of the things that you're doing that work, that really can make a difference, that have been demonstrated in New Jersey and California and every place else. So that's why I asked that question about the political will. It's a community will. It is a community taking on the fact that moms in birthing individuals and babies are really crucial, and we need to focus on all of the issues that are there. We know a lot what's working. First Lady Murphy, you identified a whole lot of things that you're doing and are making some progress. California has certainly identified it. We know what works. We just need the political will broadly defined to make that work. We need an NIH for the social determinants of health with the same kind of resources, whereas now 95% of it goes to medical care and only 5% goes to sort of the prevention activities. We need to have a little bit different balance. And so thank you for instructing us about the kind of the nature of the universe that we have to work with. So thank you all for your contributions today. And I look forward to really talking about some of those social determinants tomorrow in some of our sessions when we get back together again at noon Central or Eastern time. And so have a good night, and we will see you tomorrow.